I'm Dr. Fakir Abadi, and this is Human Immunodeficiency Virus in Adults, Part 1. Nobody knows the exact origin of HIV virus, but it probably spread from non-human primates to humans in the 1900s. If you don't treat HIV, an infected person typically progresses to death over a period of 10 years. So it's a very deadly disease. And it primarily affects men who have sex with men, which we call MSM, people who inject drugs, people in prisons and closed settings, sex workers, transgender people, and of course infants of HIV positive mothers. Now it is important to keep in mind that HIV is not transmitted by air or water, with saliva, sweat, tears, or closed mouth kissing, insects or pets, or sharing toilet food or drinks. Another important thing to keep in mind is that women have been historically underrepresented in clinical studies. This is an important thing to point out in Journal Club. And in the US, about 25% of HIV infected patients are women. Now let's take a look at the HIV prevalence worldwide in the United States and in California. So in the left-hand side, we can see a figure of prevalence of HIV worldwide. So on the y-axis, we are looking at the number of cases, millions of people. So there are 39 millions of people worldwide living with HIV. And when you compare it with some of the other conditions, you can see 58 million people live with Hep C virus, whereas 296 million with Hep B, and 463 million people with type 2 diabetes. In the United States, about 1.2 million people live with HIV, 2.4 million with Hep C, and 2.2 million with Hep B, whereas 37 million people with type 2 diabetes. And in California, those numbers are about 140. Now, these numbers are in thousands of people. So 140,000 people live with HIV, 320 with Hep C, and about 4 million people with diabetes. So in general, you are more likely to encounter patients with diabetes in the clinic than you are to see patients with HIV or Hep C, unless you are working in HIV clinic or immunosuppressive clinic. Now here in the right hand side, I have listed the top 11 counties with HIV, with the highest HIV prevalence. So LA County, San Diego County, and San Francisco County are in the top 3 with the highest prevalence of HIV cases. Now, when we look at the estimated new HIV diagnosis in the US, estimated from 2022, we can see that about 67% of cases were in men having sex with men, so either gay or bisexual, and about 22% of new cases were in heterosexual individuals, and 7% in people who inject drug. In regards to gender, the large majority of new cases were in men, 79%, with 18% in women, and about 3% in transgender men or women. And when it comes to ethnicity, we can see that the large majority of new cases are in minorities, so either Black or Hispanics, together make up about 2/3 of new cases. And when it comes to age, you can see that the number of new HIV diagnoses were highest among people aged 25 to 34. In fact, more than half of the cases, about 56% of new HIV diagnoses, were in people aged between 13 and 34 years of age. Now, let's take a look at the HIV virus itself. The HIV virus is a retrovirus, and a unique capability of it is that it's able to integrate its DNA into the host genome. Now, generally speaking, there is HIV-1 and HIV-2. In the United States, it's predominantly HIV-1, whereas in most of Africa, you will see HIV-2, which is not common in the United States. Now, HIV-1 itself has different groups. Group M happens to be the major group of HIV-1, and group M itself will be broken into several clades. So there's clade A, B, C, etc. And when you compare HIV-1 to HIV-2, HIV-1 is more prevalent and also more pathogenic than HIV-2. Now let's take a look at the structure of the virus. So you can see that the genetic content of the virus actually codes for several proteins. And these proteins, so this at the top is just the genome of the HIV. So different genes will code for different proteins. And every protein has a crucial function for the virus. So in the structure, you can see that there are some proteins that are structural proteins, like envelope proteins. So they have a very important function when it comes to cell entry. So these proteins need to bind to the host cell. And also there are a few enzymatic proteins. So for example, one of the important ones is the RT or reverse transcriptase. There's also integrase. And there's also protease. So reverse transcriptase, integrase, and protease are three of the most important enzymes of the HIV, and we actually target them with drugs. So it's important to know because the mechanism of action of some of our antiretrovirals is actually based on this. The first learning objective is describe the HIV life cycle and the mechanism of action of antiretroviral agents. HIV virus primarily affects the CD4 T cells. So CD4 T helper cells are a very important part of the immune system in the human body. So let's start here. When the virus finds a CD4 T cell, the first thing it does is that it's going to attach to the CD4 receptor. So some of those envelope proteins, they actually detect the CD4 receptor. And this process is called attachment, and we also have some drugs that will inhibit the attachment called attachment inhibitors. Now, the binding of these envelope proteins to the CD4 receptor alone is not sufficient for cell entry. So the virus also requires co-receptors. And these co-receptors are either CCR5 or CXCR4. And this depends on the virus. So some viruses prefer CCR5 and some viruses prefer CXCR4. And this is referred to as tropism. So once the virus bonds to the CD4 receptor and the co-receptor together, then the virus will actually be able to fuse and enter the cell. This process is called fusion, and we also have some drugs that block this process, referred to as fusion inhibitors. Once the virus fuses, the content of the virus will go inside the cell. So inside we have genetic material, and we have some of those enzymes that came with the virus. So for example, reverse transcriptase is one of the important ones. And if you guys remember from the central dogma of molecular biology, the process of transcription is typically from DNA transcribing into RNA. And the reason this enzyme is called reverse transcriptase is because the material that comes with the HIV is actually in RNA form, and reverse transcriptase will convert that RNA into DNA. So it goes from RNA to DNA. So it's in reverse. And what this enzyme reverse transcriptase does is that it will use nucleotide. So natural nucleotide that are in the host cell will be utilized in order to form this DNA. So we can actually target this with two classes of drugs. One class is the nucleotide analog reverse transcriptase inhibitors. So these are basically drugs that kind of look like natural nucleotides. So the reverse transcriptase will accidentally use them and insert them into this DNA. But because they're not natural nucleotides, they won't be able to make links, and then it will interrupt the transcription. So we can have nucleotide reverse transcriptase, or NUCs for short. Another class is non-nucleotide reverse transcriptase inhibitors. These are not necessarily analogs of nucleotides, but these are molecules that actually have affinity for the reverse transcriptase. So by binding to reverse transcriptase, they will actually inhibit its function. So these are called non-nucleotide reverse transcriptase inhibitors, or non-NUCs for short. And then once this DNA is made, then it will go inside the nucleus of the host. And then another enzyme that came with the virus is integrase. And what integrase does is that it will actually integrate this new DNA from the HIV and will integrate it into the host DNA. And by doing that, it will actually make the HIV genetic material as part of the host DNA. And that's why, it's, we don't currently have a cure for HIV, because its material actually gets integrated into the host DNA. Now, once this material is integrated into the host DNA, the virus doesn't have to do anything. Now, the central machinery of the host cell will actually transcribe this DNA material into RNA, and then this RNA will go and find a ribosome and translate into proteins. So, these are genes from the host as well as any gene from the HIV. So if it happens to be HIV genes here, the end product is those proteins that are required for HIV. So for example, reverse transcriptase will be made here, integrase will be made here, protease will be made here, and those envelope proteins, they will all be here, made here, and then they all assemble into a new virus which will bud and exit the cell. Now, once this new virus exits the cell, it's not mature at the beginning. So that's where protease will come in. Protease is very important for the virus because it will actually have the function of maturing that cell. So without that protease, that new HIV virus will not be able to infect other cells. So for it to become mature and then be able to infect other cells, it needs the function of protease. And because of that, we actually have a class of drugs called protease inhibitors, specifically HIV protease inhibitors, that will block this process. And these HIV protease inhibitors are different than hepatitis C protease inhibitor. So do not confuse these two different classes of protease inhibitors. Let's take a look at the pathogenesis of HIV. As you know by now, the primary route of transmission is by sexual contact. So if it's through vaginal sex, you can see that this is the mucosal layer of the vagina, so the virus can easily penetrate through this layer and enter the body. Or if it's men having sex with men, in the rectal tissue, there are dendritic cells that actually have the function of surveying the system, and this dendritic cell will actually pick up the virus to hand it to the immune system to get rid of. So regardless of which route, the virus will end up in the body and will find a CD4 T cell. It can also infect macrophages, but the primary route is through CD4. And the reason it's really important to focus on the CD4, because CD4 T cells typically are either activated or in a resting phase. When a CD4 T cell is activated, that means the cell is actually converting the genetic material into protein, whereas in the resting CD4 T cell, it's actually silent, so it's not really producing any proteins from the genetic material. And the HIV can actually infect all of them. So the reason this is important is when HIV is integrated into DNA of a resting CD4 T cell, it's hard to detect it because the virus is actually inside the DNA, and because it's not actually being converted into any protein, there are no antigens, or there are no antigens to be detected by the immune system. Whereas in an activated CD4 T cell, because of these end products, the immune system can actually detect it. It can basically kill the CD4 T cells and also cause inflammation. But because of these resting CD4 T cells, whatever HIV is in there, it will actually be archived and stay in the body of the host without the body being able to get rid of. So basically, these resting CD4 cells will act as a reservoir for the HIV material. So even though the immune system continues to fight all the infected cells, and it will continue to kill the infected cells, whether they are macrophages or the activated CD4 T cells, those latently infected CD4 T cell will continue to be there, and occasionally, they become active, but they so the body can never completely get rid of them. So two things happen. As these CD4 T cells get activated, the immune system will kill them. So because of the destruction of these CD4 T cells, the CD4 T cell count will actually start to drop because some of them are dying. Another thing that happens because of the inflammation and all this immune response is that the lymphatic tissue that's responsible for making these CD4 T cells starts to die because of the inflammation and the response of them. So because of this, we get decreased production of the CD4 cells. So there are two reasons for why HIV infected patients start to have low CD4 counts. That's because of increased destruction of the activated ones and also decreased production. So this is a progressive disease. As patients get infected, there's acute HIV infection, which initially the immune system starts to kill all of those activated CD4 cells and infected macrophages. And then there's a period of clinical latency where, there's not a whole lot of symptoms and a lot of these CD4 T cells are resting. And then over time, because of the CD4 cells count starts to drop, then the immune system will be weakened and eventually will be non-existent, and that's when the patient will have AIDS or acquired immunodeficiency syndrome. So not everyone infected with HIV has AIDS. It's only advanced HIV that we call AIDS, and by definition, it's, if the CD4 T cell count is less than 200, or if the CD4 T cell count is not available, then you can look at the percentage of the CD4. So if less than 14% of lymphocytes are CD4, this will be referred to as AIDS. Or even if someone has higher than 200 or higher than 14% CD4, but happens to get the AIDS defining condition, then this will be classified as AIDS. And those AIDS-defining conditions are actually listed here for your reference. You can see that initially a normal person has over 1,000 cells of CD4 T cells. As you can see, initially during that acute phase where there's a high level of RNA, HIV RNA, the CD4 cell starts to drop very quickly. And then the immune system will take over, and then it will be, the CD4 starts to go back up. And then at some point you reach the set point where lymphatic tissue starts to die, and then the body cannot keep up with production of CD4. And as those resting CD4 cells become active, the immune system starts to kill them. So you can see that over a few years, the CD4 count starts to drop and drop and drop. And then once it goes less than 200, that's when really, we say that the patient has AIDS, and they start to get these opportunistic infections that will kill the patient. And not just infections, but also because the immune system has the function of surveying for cancer-forming cells and destroying them. As these CD4 cells can start, these patients are also at risk of getting various types of cancer. Now, when it comes to the symptoms during the acute phase, where where there's a surge of viral load, that's when patients start to have flu-like symptoms. So typically 2 to 6 weeks after primary infections. So they're very similar to the common cold or the flu. And then beyond that, the patients become asymptomatic until the infection actually advances. So the chronic phase is basically asymptomatic until the patient gets opportunistic infections, and then in very advanced phases of the infection, you also see cardiovascular disease, cancer, and eventually death. Let's take a look at 4 classes of drugs that affect HIV cell entry. We have CD4 receptor antibody ibalizumab. Ibalizumab is a recombinant humanized monoclonal antibody, and it actually binds to the CD4 receptor on the T cell. So in this picture, you can see the CD4 receptor here, and thereby prevents conformational changes in the CD4 HIV envelope glycoprotein 120 that are essential for viral entry. So that's how it blocks entry of HIV-1 into CD4 cell and prevents its transmission via cell-cell fusion. Now, it's important to note that because this antibody binds to CD4 receptor, it actually does not interfere with the normal CD4 cell activity. So those CD4 T cells will still be functional. Next, we have CCR5 inhibitor maraviroc, which basically binds to CCR5, which is one of the co-receptors required for cell entry, and it changes its conformation and prevents GP120 CCR5 binding. Next, we have enfuvirtide, which is a fusion inhibitor. It actually mimics the GP41 protein on the virus, and by doing so, it prevents fusion with the CD4 cell membrane. And more recently, we have a new drug on the market, fostemsavir, which is an attachment inhibitor. This one binds to GP120 and basically prevents HIV virus attachment to CD4 T cell. Now, you already know the mechanism of action of nukes and non-nukes, which basically interfere reverse transcriptase inside the cell. And lastly, you also know the mechanism of action of integrase inhibitor, which prevent integration of HIV genome into the host genome. And lastly, we have protease inhibitors, because once the cell cycle continues, these proteases are needed for maturation of the final HIV virion, and protease inhibitors actually block the maturation of the new HIV virions. Now, in December of 2022, the FDA approved lenacapavir, which is a unique antiretroviral agent because it has a multi-stage mechanism of action. So essentially, it is considered a capsid inhibitor. So it binds to two neighboring subunits of the HIV capsid protein. So the capsid is inside the envelope, and it essentially inhibits the capsid-mediated nuclear uptake of pre-integration complexes, so it prevents integration into the DNA. But also, if by the time the drug is taken, the HIV DNA has already been integrated, it can act by inhibiting virion production and proper capsid core formation. So it has three different mechanisms of action, and it is FDA approved in combination with other antiretroviral agents for treatment of highly treatment experienced patients who have multi-drug resistant HIV infection, failing their current ART due to resistance, intolerance, or safety consideration. So far, we described the HIV life cycle and the mechanism of action of antiretroviral agents. Now, given a treatment-naive HIV-1 patient, recommend DHHS guideline concordant antiretroviral therapy. Let's take a look at some reliable resources. For HIV infection and anything that's associated with HIV, such as opportunistic infections, we use in the United States the DHHS guidelines. So the DHHS stands for the Department of Health and Human Services, and their guidelines actually updated at least a couple of times a year, and they are available online. So they have several guidelines. They have one for HIV-1 for use of antiretroviral agents in HIV-1 infected adults and adolescents. They have one for pregnancy. They also have a couple on pediatrics. The focus of this presentation is on adult in HIV. They also have a guideline for pre-exposure prophylaxis and a couple on post-exposure prophylaxis, along with CDC guidelines for diagnosis of HIV. Let's take a look at diagnosis of HIV. These are the recommendations from the 2014 CDC guidelines. Since 2014, it's been recommended to use an assay that's a combination of antigen antibody, and these are antigen and antibodies from both HIV-1 and HIV-2. And if this does not test positive, so if it's non-reactive, now assuming that the patient has not had a risky behavior in the previous 15 to 20 days, then we can confidently conclude that the patient does not have HIV. And this test has a very high sensitivity and specificity. It does take some time for the body to make antibodies and for the antigen levels to increase in the plasma levels. Therefore, if someone has just been exposed to HIV, this test is unlikely to detect it. Now, if someone does test positive, we don't know if it's HIV-1 or HIV-2. So therefore, we need to do another assay, which is an antibody differentiation, to figure out if this is HIV-1, HIV-2, or both. If antibodies for HIV-1 are detected but not HIV-2, we can conclude that the patient has HIV-1. If the antibodies for HIV-1 are negative but HIV-2 is positive, we can conclude that the patient has HIV-2. If both of them are positive, then the patient actually is co-infected with HIV-1 and 2. And if neither of them test positive, now we have a problem, because initially the antigen antibody tested positive, but now we didn't find HIV-1 or 2. Now, to resolve this issue, we actually need to do nucleic acid test. A nucleic acid test is a lot more accurate because instead of antigen or antibody, it actually detects the HIV RNA. So if this tests positive, then we can conclude that the patient has HIV. And currently in the US, HIV-2 is not common. So the nucleic acid tests that are FDA approved are only for HIV-1. Now, if this patient does not test positive, we can conclude that the patient does not have HIV-1. And this is assuming that the patient did not have risky behavior in the past week. So it typically takes about 6 days for the RNA levels to go high enough for this test to actually detect it. This nucleic acid test is a qualitative test, so it basically tells you if the RNA is there or not. Regardless, when someone is tested positive, we actually need to do PCR in order to quantify the viral load. The primary reason that this algorithm exists is because these antigen antibody assays are actually more affordable than the nucleic acid test. So if you're using it for screening purposes, where majority of patients will actually be non-reactive, this is a more cost-effective way of screening people. And then people who test positive will actually end up with more tests and possibly nucleic acid tests, which are more expensive. Okay, let's take a look at HIV serology. So in this figure on the x-axis, we're looking at time in units of days after exposure to HIV. And you can see that the first few days, it's referred to as eclipse period. And it basically means that it takes a while for the HIV to replicate and actually become detectable. So what we basically use to detect HIV the soonest is the nucleic acid amplification test, which basically can detect it by day 6 to 8. Whereas within the first 5 days, it's going to be undetectable. And then between days 13 and 20 is when the P24 antigen can be detected, and depending on what source you look at, you will see different numbers. So some sources say 15 to 20 days, some say 13 to 20. It's clear that around 2 to 3 weeks after exposure is when this antigen will be detected. And then it will take significantly longer for the body to make antibodies, and then those antibody tests to be detected. Now, up to 38% of new HIV infections are transmitted by people who are unaware of their HIV status. So it is important to screen people who are at risk for HIV. In fact, the 2019 USPSTF recommendations for HIV screening includes all adolescents and adults aged 15 to 65 years. And then people who are younger or older, if they have increased risk of infection, should also be screened. And of course, all pregnant persons, including those who are present in labor or at delivery, whose HIV status is unknown, should be screened for HIV. So when should treatment be started in patients with HIV? Now, in the old days, it used to be that the recommendation was based on the CD4 count. So patients who had lower CD4 count, they were at higher risk of having opportunistic infections, cancer, and of course mortality. So and of course older HIV drugs were very toxic, so we would actually reserve it for more severe patients. But nowadays HIV drugs are very effective, they're very well tolerated, And we have clinical evidence that regardless of CD4 count, when we start treatment for HIV, we can actually reduce the rate of morbidity and the rate of mortality associated with HIV infection. And this mortality could be due to cardiovascular disease, it could be due to cancer, it could be due to opportunistic infection. So it actually can be significantly high. And HIV treatment can actually reduce these numbers significantly. And of course, the other issue is transmission, and we do have very good evidence that once we start treatment, HIV transmission will be significantly reduced. And this transmission could be to sexual partners, as well as vertical transmission from infected mothers to the infant. Now, the December 2019 update of the DHHS guidelines recommend initiating ART immediately. So immediately means basically the same day that the patient is diagnosed with HIV, or as soon as possible after HIV diagnosis. And this is because it has been shown to increase uptake of ART and linkage to care, as well as achieving viral suppression faster in individuals and improve the rate of virologic suppression in patients with HIV. Now, when it comes to ART, it is very important to educate patients about the benefits and considerations of ART and to address strategies to optimize adherence. So we will talk about adherence shortly, but adherence is very important. So if there is concern about patients achieving being adherent to ART, then instead of starting ART immediately, it may be more reasonable to delay it a little bit, but do it as soon as possible. So as soon as the patient has access to care and the patient is ready to adhere to ART. Interrupting ART can lead to rebound viremia, worsening of immune function, and increased morbidity and mortality. So therefore, once ART is initiated, it has to be continued with the following goals. So the goal is to maximally and durably suppress HIV RNA in the plasma, to restore and preserve the immune function in HIV patients, to reduce HIV-associated morbidity and prolong the duration and quality of survival, and prevent HIV transmission. Now, it is common that once ART is initiated, because these regimens are very effective, that the patient can actually achieve viral load reduction within the first 12 to 24 weeks of therapy. So within 12 to 24 weeks of initiating ART, the viral load should be undetectable. And recent data has shown that in patients who have a viral load of less than 200, so in general, less than 50 is considered undetectable. So even anything less than 200, studies have shown that the rate of transmission is basically non-existent. So now we say the slogan U equals U, so undetectable equals untransmittable. And this has serious consequences when it comes to the stigma that's associated with HIV. So we're starting a new culture of U equals U, because as long as a patient is taking their ART and the viral load is undetectable, then they cannot transmit it to their partner. Now, generally there are three different strategies for ART regimens. The historic strategy would be the triple therapy, which basically would include 2 NRTIs or 2 nukes as the backbone, plus a third agent. And the third agent can be either an integrase inhibitor or a protease inhibitor or a non-nuke. So 2 nukes plus a non-nuke. Now, in general, majority of integrase inhibitors are recommended first line, so that's why this one is green, and we'll talk more about specific agents shortly. We also have dual therapy. So dual therapy could be in 2 different ways. One is that you actually drop one of the NRTIs, and the reason we do combination therapy is that, you know, HIV has a high propensity for developing resistance. So by using combination, we can basically prevent resistant development. So with the dual therapy, you basically drop one of the nukes. So you have 1 nuke plus an integrase inhibitor, which is, you know, first line. You also have 1 nuke plus protease inhibitor, which is alternative. And we'll talk about specific regimens shortly. You also have NRTI free or nuke free dual therapy. So this is basically no nuke included in the regimen. So this is basically a combination of integrase inhibitor plus a non-nuke. And the reason this is red is because it is not recommended as initial treatment. It's recommended for people who already have received treatment from another ART and achieved undetectable viral load. Then they can switch to this strategy. Another non-nuke dual therapy includes integrase inhibitor plus protease inhibitor. Now, generally speaking, majority of first-line regimens that are recommended follow this rule that you need a backbone plus a third agent. So we use 2 nukes or 2 nucleotide reverse transcriptase inhibitors as a backbone plus a third agent. So it's important to have this combination in order to prevent HIV from developing resistance. And generally speaking, we have 3 backbones that are commonly used. So we have Epzicom, which is a combination of lamivudine and abacavir. We have Truvada, which is emtricitabine and tenofovir disoproxil fumarate. And we have Descovy, which is a combination of emtricitabine and tenofovir alafenamide. And I'll explain what's the difference between tenofovir disoproxil fumarate and tenofovir alafenamide shortly. Now, lamivudine and abacavir are 2 nukes that are commonly used in combination in Epzicom. So this will be 1 pill that would be used as a backbone. So if you are to use Epzicom as the backbone, you still need a third agent to go with it. Between lamivudine and abacavir, lamivudine also has activity against hepatitis B. Abacavir does not. So it's important to make sure that you are aware whether the patient also is co-infected with hepatitis B. Because, for example, if we are using something that covers hepatitis B and then later you decide to switch it to something that does not cover hepatitis B, the patient can have reactivation of Hep B and possibly Hep B flares, which could potentially be fatal. Now, all of these drugs in this class of NRTIs or nukes, because they actually are analogs of nucleic acids, that means that any RNA or DNA transcriptase can or polymerase can actually use this. So especially with the older NRTIs that we no longer use, they had an affinity for human mitochondrial DNA. Because of that, they were associated with lactic acidosis. And this became a black box warning, which, for the entire class. So these new drugs that we use, or I should say relatively newer, compared to the drugs from the 80s, these have lower affinity for mitochondrial DNA, and therefore they are not likely to cause lactic acidosis. But regardless, the FDA has this black box warning for all NRTIs. One thing that's specific with abacavir, before anybody can be started on abacavir, we should actually do a genomic polymorphism test of HLA-B 5701, and you should only start abacavir if someone tests negative for HLA-B 5701. And that's because people who test positive for HLA-B 5701 are at least they have a at least 50% increased risk of having fatal hypersensitivity reaction to this drug. So it's crucial to test this before starting abacavir. So that becomes one of the limitations of using abacavir, because you cannot. So if somebody tests HIV positive and you want to use this, you have to order this test, and it typically takes a few days, around a week, to come back. So it kind of delays therapy, but some patients may have no other option, so we have no choice but to test this, and then once they test negative, we can start a regimen that includes abacavir. Now, all NRTIs are renally cleared except abacavir. So abacavir is actually cleared hepatically, so you may need to dose adjust it in patients with mild hepatic dysfunction, whereas all other NRTIs actually need to be renally adjusted. So, for example, lamivudine, creatine kinase cutoff is 50. Now, as a class, all NRTIs can cause nausea, vomiting, headache, rash, and increased liver enzymes. Lamivudine specifically is very well tolerated in general, but it does, cause in some patients fatigue and insomnia. Abacavir, of course, can cause hypersensitivity reaction, especially if patients have HLA-B 5701. So HLA-B 5701 positivity is a contraindication, and of course it can also cause fatigue. Now, when it comes to the other combinations for the backbone, we have either Truvada or Descovy. So Truvada was their first, which is a combination of emtricitabine and tenofovir disoproxil fumarate. And these two combinations, both of them cover hepatitis B, and of course they still have this lactic acidosis black box warning, which all NRTIs do. And both of them are renally cleared, so creatine kinase cutoff of 50 for these two. TAF, or tenofovir alafenamide, is a newer formulation of tenofovir, which is actually creatine kinase cutoff is lower, so you can actually still use it in some patients with CKD. Generally speaking, these drugs are very well tolerated. Emtricitabine specifically can cause hyperpigmentation. TDF can cause nephrotoxicity and bone mineral loss, and this in fact is the reason that we actually came up with a new formulation of tenofovir alafenamide, which still does have nephrotoxicity and bone mineral loss, but it's significantly less compared to TDF, and I'll explain that more. Now, note that this tenofovir does not cause bone toxicity in the sense that it does not cause bone marrow suppression. It just causes some bone mineral loss. So this is not the same as bone mineral suppression. This just increases the risk of osteoporosis. Now let's take a look at the difference between TDF and TAF. So tenofovir itself is the actual drug. Tenofovir is the actual drug that's an analog of a nucleotide, and that's what needs to go inside the target cell to block HIV replication. The problem is when you orally take tenofovir, it's actually not absorbed. So this part is the GI tract, and when you take a pill of tenofovir, you would like it to be absorbed and go into the blood, and then the blood, in the circulation, HIV actually is inside the CD4 cell. So the target cell is the CD4 cell. That's where HIV replicates. You want this tenofovir to be absorbed into the blood, and then from the blood to go to the CD4 cell, and then find the HIV virus and block its replication. The problem is tenofovir is not absorbed. So we had to do something. We had to come up with some sort of salt formulations that increases absorption. And that's why we had TDF. So tenofovir disoproxil fumarate actually gets absorbed from the GI tract. So if you were to give 300 milligram, it gets absorbed. And then a tiny portion of what gets absorbed goes to the target cells, CD4. Okay, and that's how much we need in the CD4 in order to prevent replication of HIV. Now the problem is the majority of this tenofovir is staying in the plasma where we don't need it, and guess where it goes? It goes to the kidneys. It's gonna go to the kidneys and it's gonna cause nephrotoxicity. It's also gonna go to the bones and cause bone mineral loss, things that we do not like. So this has become a problem because patients need to be on these drugs for life, and over time this can build up, and patients will start to have CKD, or if they already have CKD, the CKD will progress. And as we all know, as we age, we also are all susceptible to bone mineral loss due to just aging, and this will actually accelerate it. So people who have HIV and are aging and are on TDF, they actually will lose more bone mineral. So we came up with TAF, which is a different salt form. So it actually absorbs. So when you take this orally in the GI tract, it gets absorbed. Now, majority of this goes into the target cell, so you get the same amount in the CD4 where you actually need it, and then a tiny portion of it stays in the blood where it's gonna go to the kidneys and it's gonna go to the bones and it's gonna cause some toxicity. But because this is a significantly lower concentration in the blood than compared to TDF, it has significantly less nephrotoxicity and bone mineral loss, and therefore we're starting to use more and more TAF compared to TDF because the efficacy is the same, because you get the exact same amount in the CD4 cell, and that's exactly why you see a huge difference in the dose. So TDF you need 300 milligram, and TAF you need 25 milligram in most regimens, unless you have like a inhibitor where you would use a 10 milligram. So if you have cobicistat in the regimen, for example, you will see 10 milligram. So which regimen should be initiated in a person living with HIV who has not received treatment in the past? So for people without a history of using cabotegravir as HIV pre-exposure prophylaxis, which is essentially most patients who are diagnosed with HIV, DHHS guidelines recommend a second generation bictegravir combined with a backbone of 2 NUCs. So we have bictegravir, which is a second generation integrase inhibitor combined with emtricitabine and tenofovir alafenamide, and this is available as a single tablet regimen, Biktarvy. We also have dolutegravir based regimens. We can have a combination of dolutegravir plus emtricitabine tenofovir, so either tenofovir alafenamide or disoproxil fumarate. This essentially means that you would need 2 tablets, either TBK, which is the dolutegravir part, plus the backbone of Descovy, or TBK plus Truvada. So this will essentially have patients on two pills. We also can have dolutegravir plus lamivudine tenofovir. So it's either TBK plus Simduo or TBK plus Temixis. We also have a combination of dolutegravir plus a single NUC as a backbone. So this essentially has lamivudine as the only backbone, and this is available as a single tablet regimen, Dovato. These regimens are recommended first line because they are very effective, they have a high barrier to resistance, and they are well tolerated, and they have minimal drug interaction. So these are essentially work very effectively for most patients. Now, for people who have a history of using cabotegravir as HIV pre-exposure prophylaxis, so essentially cabotegravir is an integrase inhibitor, and patients were taking it to prevent getting HIV, and they got HIV anyway because they could potentially have integrase inhibitor resistance. For these patients, we do need the results of HIV resistant testing before we can start these first-line recommended regimens. In the meantime, if we are to start ART while we wait for the results of the resistant testing, it is recommended to use a boosted darunavir regimen for these patients. So darunavir can be boosted by either cobicistat and ritonavir, and what this means is that cobicistat is essentially a potent inhibitor of CYP enzyme. So by inhibiting metabolism of darunavir, it boosts its levels. So does ritonavir. Ritonavir itself is actually an HIV protease inhibitor like darunavir, but it's such a potent inhibitor of CYP enzymes that we use them at such a low doses that it's not likely to do anything to HIV, but it has significant boosting effect on darunavir. Now, with darunavir cobicistat with the backbone of emtricitabine and tenofovir, it does come as a single tablet regimen, Simtuza, but also we can take multiple tablets. So Prescobix, which has darunavir and cobicistat in it, with a backbone of either Descovy or Truvada. When it comes to ritonavir boosting, darunavir and ritonavir are separate pills. So Prezista is darunavir, Norvir is ritonavir, and then we can have backbones of 2 NUCs added to that. Now, one thing that I do want to mention as far as first-line recommendation with dolutegravir and lamivudine, because it only has a single agent as the backbone, there are three things to consider. One is that because it only has one drug active against Hep B, people who have Hep B co-infections do need another regimen to be active against Hep B, because Hep B can develop resistance against this. In other words, people who have Hep B co-infection, when you have emtricitabine and tenofovir, so we have two drugs that are active against Hep B, those are fine. But when you drop one of the Hep B active agents, then you should have another agent on board to avoid Hep B resistance. The second thing to consider is that we have to make sure that the baseline HIV RNA is less than 500,000 for patients to take this. Otherwise, if the baseline RNA levels are more than 500, they cannot take this. They have to take something else to reduce the viral load before they qualify for this. And the third one is that only HIV, only for patients who had genotypic resistant testing performed to rule out resistance. Now, the third group of people to consider is, what if the results of the resistant testing comes back and the patient actually has an integrase inhibitor resistance. So for these patients, we have, as mentioned, boosted darunavir regimens that we can consider. Now, this obviously comes with a lot of drug-drug interactions. So if drug-drug interactions are prohibiting the patient to be on these regimens, other options are doravirine-based regimens. So we have a single tablet regimen, Delstrigo, which has doravirine, lamivudine, and TDF in it. There's also, if someone doesn't want the TDF and TAF is preferred, then 2 tablets can be used. So doravirine plus Descovy as the backbone. And then also we have rilpivirine as a single agent. So Complera has TDF in it and Odefsey has TAF in it. But essentially, this is perhaps the last as a last resort here, because patients who take rilpivirine, we have to make sure that at baseline the RNA level is less than 100,000, and the CD4 count has to be at least 200 or higher in order for patients to take this. Otherwise, if the CD4 is less than 200, or if the viral load is more than 100,000, this is not going to be as effective. Now, obviously, some patients cannot tolerate tenofovir, so because of the bone toxicity and the renal toxicity. So, for example, if someone has osteoporosis, perhaps tenofovir is not the best agent for these patients, given that they need to be on this for a very long time, perhaps lifelong. And also patients who have nephrotoxicity, because we have other agents that are not nephrotoxic, it's best to avoid tenofovir. So these are the tenofovir sparing regimens. So as mentioned previously, dolutegravir, lamivudine is actually first line even for patients who don't have a need for avoiding tenofovir. That's a good regimen as long as the viral load is less than 500,000. Other available options are dolutegravir, abacavir, and lamivudine. So this essentially doesn't have tenofovir, but the 2 backbones includes abacavir. Now, in order to use abacavir, it is important for patients to have a test called HLA-B 5701 in order to safely start. So if the results of this test is not available, we cannot start abacavir. So anything that has abacavir cannot be started, because patients who have these HLA-B 5701, they're very likely to have a hypersensitivity reaction that can be fatal. So Triumec essentially is good for patients who should avoid tenofovir, but also have a viral load of greater than 500,000. So if they don't qualify for Dovato, then they can get Triumec. One last point about abacavir is that it is associated with increased risk of cardiovascular disease. So for patients that have either established cardiovascular disease or if they have multiple cardiovascular risk factors, it is recommended to consider avoiding abacavir-based regimens. Now here you can see the regimens that are no longer recommended as initial ART. So raltegravir and elvitegravir are both first generation integrase inhibitors, and because they have low barrier to resistance, they are no longer recommended. Dolutegravir also has the problem of having high pill burden, so this is multiple pills. It is not available as a single tablet regimen. Bictegravir cobicistat is available as a single pill, single tablet regimen, but unfortunately, because it's pharmacokinetically boosted, it has drug-drug interaction. So other drugs that are being given to the patient needs to be checked for interaction. So for that reason, it's complicated and it's no longer recommended as first line. Boosted atazanavir, because of its toxicity, specifically hyperbilirubinemia. In fact, some clinicians refer to atazanavir as bananavir because patients typically get a yellowish skin because of this liver toxicity. And because it's boosted, it has drug-drug interaction, so it's not recommended. Efavirenz not only has a low genetic barrier, but the toxicity includes the neuropsychiatric effects as well as suicidality, and it also has many drug-drug interactions. So it really is not recommended as a first line, and patients in general should not be on efavirenz-based regimens, since we have many other regimens that are effective and well tolerated. And as we discussed before, rilpivirine has restrictions, so RNA levels need to be less than 100,000 at baseline, and CD4 needs to be greater than 200, and it needs to be taken with food in order to increase absorption. So for that reason, rilpivirine is based regimens as far as 3 drug regimens is not recommended. Now, those were recommendations for initial therapy. Once somebody's started on regimens and the viral load is undetectable, there may be opportunities to optimize ART based on adverse effects, drug-drug and drug-food interactions, number of pills, whether the patient is getting pregnant, cost may be an issue, stigma, and for example, if it's an oral regimen that's visible to friends and colleagues, that could cause stigma issues for the patient. So perhaps an injectable that's not visible to other people might be a strategy to overcome this, and many other things that we can factor. So in general, there are 3 things we can do to optimize. One is that once somebody's viral suppression is achieved, you can pretty much switch to any other thing that's first line, because they're being shown to be highly effective. But also, there are a couple of agents that I'd like to touch base on. One is Juluca, which has dolutegravir and rilpivirine. So this is essentially an integrase inhibitor plus a non-nuke. And because it does not have a nuke, it essentially doesn't have any component that's renally clear. So when you have patients with renal dysfunction, this essentially becomes pretty a reasonable option, as well as for anybody that needs to avoid toxicities of all the nuke agents in general. The other one, which is and by the way, Juluca is an oral agent, and then we have an injectable option. So these are long-acting cabotegravir and rilpivirine. So these are 2 injections, intramuscular injections that will be done at the clinic, and essentially there are two long-acting options. So one is like monthly options. We also have a longer acting that's injected every 2 months. So this helps for people who don't want to take a pill every day, and they essentially get the injection every 2 months. And in order to qualify for this, the patient must have had a viral suppression for at least 3 months, and there should be no history of resistance to cabotegravir or rilpivirine. And because this has not been tested in pregnancy, it's important to make sure that the patient is not pregnant and is not planning to be pregnant. Now, because these are long-acting, there's always the risk that if somebody is going to have a hypersensitivity reaction, then this drug is in the system for 2 months. So if there is a concern for that, there is an oral option that's a short acting. So this is essentially taken daily, just to make sure that the patient tolerates it. So if they're getting cabotegravir and rilpivirine for the very first time, and you want to make sure that they're not allergic to it, Vocabria is an option before they switch to the long-acting, but it's optional because what we have seen in the studies is that the large majority of patients tolerate this, so hypersensitivity, reactional allergies are extremely rare to these drugs. We described the HIV life cycle and the mechanism of action of antiretroviral agents, and given a treatment-naive HIV patient, we recommended DHHS guideline concordant antiretroviral therapy. Now, when indicated, let's recommend immunization to patients living with HIV. Generally speaking, the immune response in people living with HIV is significantly lower. Even when the patients are receiving ART, the CD4 T lymphocyte remains significantly lower compared to people who do not have HIV. Even the B cell activation will be impacted by HIV, and this is most likely due to the persistent inflammation. Even in patients who have undetectable viral load, this inflammation persists. And in general, recommendations for vaccinations are similar in HIV patients, with the exceptions of a few contraindications in HIV patients, especially with CD4 count less than 200, because they will be severely immunocompromised, especially when it comes to live vaccines. In general, the data for vaccine effectiveness in HIV is very low, which has led to under-vaccination in people living with HIV. So we need to do a better job of vaccinating HIV. Let's take a look at ACIP recommendations for adults. For each vaccine listed in this table, we're going to look at recommendations for healthy people without HIV, and then we're going to look at recommendations for people living with HIV in two categories. One is people with AIDS, essentially CD4 count less than 200 or less than 15%, and these are considered severely immunocompromised, and those who have CD4 at least 200 or higher. For the general population, inactivated or recombinant influenza vaccine is recommended annually for the annual updated influenza vaccine. People living with HIV are at increased risk for influenza severity, complications, hospitalization, and mortality compared to healthy individuals. So it is, of course, also recommended that these individuals receive annual influenza vaccine. Of note, the live attenuated influenza vaccine is contraindicated with people living with HIV regardless of CD4 count. Whereas the general population, as long as they are aged 2 years to 50 years, they can receive live attenuated influenza vaccine, which is flu-mist. For pneumococcal vaccines, for the general population, for healthy individuals aged 50 years or older, a PCV vaccine is recommended. And of course, if someone received PCV 15, it should be chased with a PPSV 23, which we will discuss in more detail on the next slide. They are also recommended for people living with HIV. They should receive PCV vaccine even prior to age 50. Hepatitis A vaccine is recommended for individuals who are at risk, and some of the increased risk for hepatitis A includes HIV, men having sex with men, either injectable or intranasal drug use, cirrhosis, or people who are homeless. For hepatitis B, the general population is recommended to receive a vaccine up to age 59 years. For people with HIV, regardless of age, it is recommended to receive hepatitis B vaccine. Other risk factors that require hepatitis B vaccine includes people with Hep C, people who inject drugs, those with cirrhosis, with sexual risk, or men having sex with men. Tetanus and diphtheria is recommended as a booster every 10 years for the general population, and that includes people living with HIV. When it comes to meningococcal vaccine, there are different serotypes. So serotype ACWG and why is recommended for people who have HIV, whereas for the general population, only certain individuals at risk need to get this vaccine. For people who live with HIV, regardless of CD4 count, they need to get boosted every 5 years. Serotypes A, C, W, and Y are more likely to cause meningitis in people living with HIV, whereas serotype B is not a high risk. So therefore, HIV is not an indication for getting Men B. However, if they have other indications such as asplenia or complement deficiency, patients may receive Men B. And there are some formulations that combine all 5 into the same shot that may be available in the US nowadays. HPV vaccine is recommended for all individuals regardless of HIV status up to age 26. And then from age 27 to 45, it is a shared decision making for that group. Varicella vaccine is a live vaccine. It is recommended for individuals born after 1980. And it is contraindicated in individuals with CD4 count less than 200, since this is a live vaccine. However, it is safe to give to people with CD4 of 200 or more. And for people who have HIV, consider 2-dose series 3 months apart. For the Shingrix or recombinant zoster vaccine, it is recommended for all individuals regardless of HIV status after age 50. RSV vaccine has become available in recent years, and it is recommended for all individuals aged 75 years or older, regardless of HIV status, and for people aged 60 to 74 who are at increased risk of severe RSV, they may also receive this vaccine. Mpox, formerly known as monkeypox, there is a vaccine Jynneos that is recommended for persons at risk of Mpox infection, and this happens to have characteristics of sexually transmitted infections in recent time. So people who have HIV or other STIs are more likely to benefit from this vaccine. And last but not least, the COVID vaccine. It is recommended that people who are at risk of severe COVID-19 receive their annual vaccine, and that includes people aged 65 or older, or those who have comorbidities. With regards to patients who are immunocompromised, and that includes CD4 less than 200, an additional dose may be necessary. In other words, if normally a person receives a single shot annually, a CD4 of less than 200 would require 2 doses annually because of the immunocompromised status. And here's a more detailed look at pneumococcal vaccines. So in general, these are indications for receiving pneumococcal vaccine prior to age 50, and that includes HIV infection. So for those with HIV infection, regardless of CD4 count, once prior to age 50, they can receive either PCV20 or PCV21, and if they do that, they are done. There is no need for PPSV23. Alternatively, they can receive PCV15, and 8 weeks later, at least 8 weeks later, they can receive PPSV23. Now, if for some reason somebody has already received PPSV23, a year later, at least a year later, they can receive one of the PCV vaccines, and that will complete their pneumococcal vaccination. We described the HIV life cycle and the mechanism of action of antiretroviral agents, and given a treatment-naive HIV patient, we recommended DHHS guideline concordant antiretroviral therapy. And when indicated, we recommended immunization to patients living with HIV. Now, given an HIV patient, let's design an individualized monitoring plan. First, let's take a look at a few definitions. Viral suppression by definition is a HIV RNA level that is below the lower limit of detection of available assays. In clinical trial, usually this is considered a viral load less than 50 copies per ml. Virologic failure is any time where viral load is actually more than 200 copies per ml. Incomplete virologic response if is if the viral load is greater than 200 in 2 consecutive viral loads that are separated by 24 weeks. So if you get a single level that's greater than 200, it doesn't necessarily mean that it's a complete virologic response. You have to look at the trend. So it could be that the viral load is greater than 200, but it's trending down. So it's important to get a second one and to see if it's trending down or up. Virologic rebound is when a patient has virologic suppression, but then after virologic suppression, then the viral load becomes greater than 200 copies per ml. And a virologic blip is once the patient gets virologic suppression, then there's a single isolated detectable RNA level, and then the patient goes back to suppression. So this is a quick virologic blip. And of course, low-level viremia is if the virus is actually detected, so greater than 50, but actually less than 200. Let's take a look at what happens when we actually initiate ART. In an uninfected person who does not have HIV, a normal CD4 count is usually around 800 to 1200 cells per microliter or more. In HIV infected patients, the CD4 count starts to drop. So for most patients, about 200 to 500. And of course, once CD4 count drops to less than 200, at that point, the patient has AIDS. Alternatively, if the percentage of lymphocytes that CD4 is 14% or less, that also constitutes AIDS. Now, once we initiate ART in the first month, so within 30 days, you should suspect a 2-log drop in viral load. So, for example, if, and of course, every log is you basically drop a 0. So, if the viral load is 100,000, a 2-log drop would be you just take out 2 zeros out, so it would be 1,000. So, you would expect the patient to go from 100,000 to 1,000 within the first month. And then 3 to 6 months, you should have undetectable viral load because the ARTs that we currently have on the market are highly effective. Now, when it comes to CD4, within the first year, it's expected that the patients will gain about 150 to 250 CD4 cells, and this levels off beyond 2 years, so this will not continue to go up to normal. So the goals of therapy is to have an undetectable viral load and to have CD4 count of at least 500. And that's because typically less than 500 is when opportunistic infections start to emerge, especially if it's less than 200. Let's take a look at monitoring parameters for HIV. So you can see, so green means that you basically need to get this laboratory parameter for everyone. And yellow means that for some patients, you also may need to do that. So at baseline, before we actually start ART, we need to check a viral load, CD4 count. We also need to check HIV resistance to make sure the regimens that we choose initially are actually working, because there's a possibility that the patient can get a resistant strain from somebody else. It's important to check for hepatitis B serology and for hepatitis C. Risk factors for getting HIV are similar to risk factors for getting Hep B and Hep C, so it's important to get these and treat these at the same time as HIV. Urinalysis is important for monitoring the renal function. So for example, you can measure the urine protein as well as urine glucose, which normally should not be in the urine, but people who have renal dysfunction will have glucose and potentially protein in the urine. So that's an easy way of monitoring renal function. And then for more comprehensive monitoring, a basic metabolic panel as well as liver chemistries and complete blood cell count are needed at baseline. And because HIV patients are at risk of cardiovascular disease, it's important to get a baseline fasting lipid panel and a fasting glucose or A1C, so that if these are abnormal, they get the appropriate treatment. And if you are to use abacavir, you need to get the HLA-B 5701. If you are not using abacavir, this is unneeded. And tropism test is only needed if the patient is to be started on Maraviroc. So if the Maraviroc is not needed, this test is unnecessary. And then 2 to 8 weeks after ART is initiated, it's important to get the HIV viral load. Now, if the patient's viral load is undetectable 2 to 8 weeks, then you can monitor it every 3 to 4 months. However, if the viral load is not undetectable 2 to 8 weeks, it's important to continue to monitor the viral load more frequently, so every 4 to 8 weeks until it's undetectable or at least is less than 200 copies per ml, and then you can switch to every 3 to 6 months. Now, for patients who actually have good adherence and they have suppressed viral load, you can actually make this easier and do it every 6 months. But that's only if the patient is adherent and the viral load at this point it was suppressed. So at the very least, the viral load needs to be monitored every 6 weeks. And if the patient's treatment fails, it's also important to check the viral load, and in fact, that's how you would know if the treatment is failing. And of course, situations were clinically indicated. For the CD4 count, once you start ART, it takes about 3 months for the CD4 cells to increase, so it's unnecessary to get one 2 to 8 weeks later. So typically, it's recommended to wait 3 to 6 months to get the CD4. And this is only needed if the patient's CD4 count was low or if the viral load is undetectable. Otherwise, if the CD4 count was already high, so greater than 300, and if the viral load is undetectable at 2 to 8 weeks, it's unnecessary to continue to monitor CD4 count because there will be no reason for the CD4 count to go any lower. Now, beyond 2 years, if the patient's CD4 count is still low, if the viral load is suppressed and they are adherent, you can actually make that easier and do it every 12 years or annually. And of course, anytime treatment fails, you should check viral load as well as the CD4 count, and if as clinically indicated. So clinically indicated, it just depends on the situation. You have to use your judgment because we couldn't possibly, or I should say, the guideline couldn't include every possible scenario. They just have the things that you should check as clinically indicated based on clinical judgment. HIV resistance is needed at baseline, but then you don't really need to do it unless the patient has treatment failure or you have some reason to believe that there is resistance. Otherwise, it's not really needed. The same with Hep B and Hep C, you definitely need it at baseline. If someone is at risk of getting Hep B or Hep C, or especially with Hep B, if they're unvaccinated, it's good to check these annually. Urinalysis that you need at baseline for renal function monitoring, you really need to get that every 6 months if someone is on tenofovir, so either TDF or TAF, because these are nephrotoxic. It's important to get urinalysis every 6 months. Otherwise, if someone is not on tenofovir, then you need urinalysis once a year or every 12 months, and if clinically indicated. For BMP and liver chemistries, you do get them at baseline and then 2 to 8 weeks just to make sure that the patient is tolerating the drugs, and then every 3 to 6 months just to make sure the drugs are not causing any toxicity. With the complete blood count, you do it at baseline, and then anytime that you need to get the CD4 count, for example, if you do need the CD4 count every 3 to 4 months, you also get the CBC. But at the very least, it's also recommended to get it every 6 months, and if clinically indicated. For the fasting lipid panel and glucose and A1C, you only need it annually, so at baseline and then every 12 months, unless if they were abnormal at baseline. So if someone's lipid panels was abnormal, you should do it twice a year. And the same with A1C. If A1C was abnormal or glucose, you should do it every 3 months. HLA-B 57, you really don't need to repeat it once you get it at baseline. And that's only if you need abacavir. So if abacavir is not in the picture, you never need the HLA-B 5701. Tropism, you only need it if someone is on Maraviroc. If the Maraviroc is not in the picture, you never need it. So if you are to use Maraviroc, you need it at baseline. And then if the patient has treatment failure, you need to recheck tropism, and if clinically needed. You can use Maraviroc if the tropism test shows CCR5, not CXCR4. We described the HIV life cycle and the mechanism of action of antiretroviral agents, and given a treatment-naive HIV patient, we recommended DHHS guideline concordant antiviral therapy. When indicated, we also recommended immunizations to patients living with HIV, and given an HIV patient, we designed an individualized monitoring plan. Now, given a prescription for antiretroviral agents, let's provide patient counseling for adverse effects and proper administration. All right, let's take a look at the food requirements for these various antiretroviral regimens. For many of these regimens, there is no food requirement, meaning that the patients can take them with or without food. However, note that anytime you have bictegravir, it needs to be taken with food, as well as anytime you have rilpivirine in the regimen. So, Odefsey and Complera have rilpivirine, so that requires food. Juluca also has rilpivirine, so because of the rilpivirine component, food is required. And also in general, protease inhibitors, darunavir and atazanavir, they require food. That's to improve absorption. Efavirenz is the opposite. So efavirenz should actually be taken on empty stomach. And again, even for efavirenz, food will increase absorption. But because there are such neuropsychiatric adverse effects with efavirenz, we actually want to minimize the absorption of efavirenz. So that's why it's recommended to take it on empty stomach. In fact, so much so that more recently, a new formulation of efavirenz came to the market with a lower dose, just to make it more tolerable for patients. Let's take a look at the safety profile of some of these combination regimens. So lamivudine is included in Epzicom, and it's generally well tolerated. As a nuke, it generally can cause, general headache, some GI issues, fatigue, insomnia, and some increases in liver chemistry, but nothing too serious, including rash. So in general, these are very mild and very well tolerated. Now, these are the newest nukes. Some of the oldest nukes that are no longer used, they used to have strong inhibition of DNA polymers in patients, which would lead to lactic acidosis. So because the mechanism of action is the same, you will see that lactic acidosis will listed in the package insert of any nukes, but the risk is very minimal. For abacavir, of course, there is a risk of fatal hypersensitivity syndrome, so it is important for patients to have a HLA-B 5701 allele. And this actually is 5 to 8% prevalent in Caucasian population. Symptoms of this hypersensitivity reaction includes fever, abdominal pain, and rash, and usually is within 2 weeks of starting abacavir. But because it can be fatal, if this occurs, it must be discontinued. Abacavir must be discontinued. Lastly, abacavir has been associated with increased risk of cardiovascular disease in observational studies, although the data is mixed on this because we have so many other safe agents available. It's best to avoid abacavir in patients with established cardiovascular disease or if they have multiple risk factors. Let's take a look at Truvada and Descovy. So tenofovir, in general, if this mnemonic helps, there is a NOF in tenofovir. So N for nephrotoxicity, O for osteotoxicity, and F for Fanconi syndrome, which is, basically wasting of electrolytes in the kidney. But Fanconi syndrome is very rare. Now, with osteotoxicity, it's important to note that this is actually talking about bone mineral density loss. It is not myelosuppression. Of course, TAF can reduce nephrotoxicity and osteotoxicity with tenofovir. And lastly, emtricitabine has this unique adverse effect of hyperpigmentation in addition to GI adverse effects as well as mild increase of liver chemistries. With Stribild and Genvoya, which include bictegravir, they should be taken with food. Bictegravir is generally well tolerated. One thing that may occur in up to 39% of patients is proteinuria. And the cobicistat component can actually cause a small increase in serum creatinine, which can actually artificially lower GFR. We'll talk more about that in a future lecture. Bictegravir does not need boosting, so it's a much smaller pill, so it's very easy to take. It's once a day single tablet regimen, and it's very well tolerated. Now, these are the formulations that include dolutegravir. So dolutegravir alone is TVK, and then with 2 nuc backbones is Triumeg, and then with a single nuc backbone is Dovato, and of course with the non-nuc, Juluca is dolutegravir plus and non-nuc rilpivirine. Now, in general, dolutegravir is well tolerated. One thing that may occur in some patients is insomnia, and also dolutegravir has been associated with weight gain. And in recent time, more data has emerged that this weight gain can be problematic, especially in patients who already have issues with pain management and are at risk of cardiovascular disease. One thing to note with Dovato, because it has a single agent against hepatitis B, there is a black box warning that if someone does have hepatitis B co-infection, there has been lamivudine resistant emerge. So that's important to screen patients for Hep B and make sure that the patients do not have Hep B co-infection when using this regimen. Isentress, which is raltegravir, this was one of the oldest integrase inhibitor. The issue is that you have to take it twice a day, so it makes it challenging for adherence. And more recently, a higher dose, so HD is for higher dose, came to the market. So basically you can do it once a day, but still these are pretty much big pills, and the patients have to take 2 pills once a day. And one unique adverse effect of raltegravir is CPK elevation. So this is, if you remember from daptomycin, can also increase CPK. So that's something to keep an eye on with raltegravir as well. Next, we have Cabenuva, which is a combination of cabotegravir, which is an integrase strand transfer inhibitor, and rilpivirine. Now, this is the long-acting version of rilpivirine with a half-life of several weeks. Now, it's co-packaged. It's not co-formulated. It's co-packaged, meaning that there will be 2 vials in the package. So there is 1 vial for cabotegravir and 1 vial for rilpivirine, and the content of the package shows that they actually give you everything you need, including the syringes and the needles. These are intramuscular injections that are injected monthly, and most recently was also approved for injections every other month. This is significant because of the monthly injections or every 2 months injection. It could potentially improve adherence, and also it can help with stigma. So if patients don't want to have a bottle of ART regimen laying around their home, and they can just get this injection. Now, because of the very long half-life of these 2 agents, there is concern that if you just inject it into somebody and they're going to have adverse effect, or if they don't tolerate it, the drug will be in their body for a very, very long time. So there was an optional oral lead-in where you actually give the short-acting version of these drugs, which are PO, and then see if the patients can tolerate before they transition to the intramuscular injections. Initially, this oral lead-in was required, but more studies came out that they actually found that the injections are very tolerable, so it's really no concern. But that's something that can be discussed with the patient if they're not comfortable getting these long-acting agents in case they don't tolerate it. There's the option to give the oral version to see if they tolerate it, and the oral version is called Vocabria. Now, another thing about this regimen is that for patients who are treatment naive, they do need to have their viral load suppressed before they can get this drug, because there's only 2 agents in there. So essentially, they need to be on another ART regimen and have undetectable viral load before they can switch to this, to make sure that resistance doesn't occur. And that's for now. In the future, as more studies come out, that may change in the future. But currently, patients need to be treated on another regimen and have undetectable viral load before switching to Cabenuva. Now, anytime you have protease inhibitors, so darunavir and atazanavir, they have to be taken with food. Darunavir specifically is a sulfa drug, so we have discussed sulfa allergy before. It's not necessarily a contraindication, but something to be cautious, especially if you have so many other options. And someone has sulfa allergy, you can use something else, because adherence is extremely important. So the last thing you want is someone is having a reaction because of this sulfa reaction and they stop taking it. Now with protease inhibitors, typically this lipidemia can occur, so especially increased triglyceride and cholesterol. So that's something to keep an eye on, especially with HIV patients. HIV itself is a risk factor for cardiovascular disease. One more thing with atazanavir is that a unique adverse effect is unconjugated hyperbilirubinemia. So that's something to monitor when patients are on atazanavir. Which basically, some of the manifestations is, when they have hyperbilirubinemia, they can actually start to look, have a yellowish color. So, some clinicians call this bananavir, referring to the yellow color. But, given that we have so many other options, they're really not a good reason for people to be on atazanavir anymore. Relpeverin should also be taken with food. The non-nukes are only active against HIV-1. They don't have activity against HIV-2, which in general is not an issue, because HIV-1 is the most, by far the most common virus in the US. And, it can cause rash, hepatotoxicity, hyperlipidemia. So this also includes increased in triglyceride as well as increased LDL. And if patients were to overdose or achieve supratherapeutic concentration, it has relpeverin can also cause QTc prolongation. Efavirenz, of course, should be taken on empty stomach, because food increases its level to unsafe levels, and there are serious adverse effects, so including depression and suicidality, including people who attempted suicide. So it's a very serious adverse effect. So it's important that the patients take it on empty stomach, or if they already have psych issues at baseline. In general, it's best to avoid this regimen, but if there is no other option for the patient, the lower dose is an option. CNS side effects, occur in up to half of the patients, and basically they resolve after 2 to 4 weeks. So these are general CNS side effects, such as confusion, abnormal dreams, somnolence, impaired concentration, and occasionally severe depression. Now, one thing that also helps with abnormal dreams is if we tell the patient to take this at bedtime. Because if you take it in the morning or throughout the day, by the time it's bedtime, the drug is in the system and it can cause vivid dreams. And these dreams are, very problematic. Patients remember them, and, it can be very problematic. So one strategy is to, if someone develops vivid dreams, to take it at bedtime, because by the time the drug kicks in and you have sufficient concentrations in the blood, it's almost morning, so the patient is waking up, so there is less likely to be, those vivid abnormal dreams. And lastly, we have doravirine, which is also a non-nuke that was recently approved, and it compared to other non-nuked, it has improved safety profile, including less neuropsychiatric side effects, as well as better lipid profile. In fact, it does not increase LDL and triglyceride, and it's also been shown to, if anything, it's going to reduce or lower LDL and triglyceride levels, and it may also, on the other hand, increase HDL levels. So, from a lipid profile, this drug seems pretty good, given that HIV patients are at risk of cardiovascular disease. The other advantage of this drug is higher barrier to resistance, including it has been shown to maintain its activity against viruses that are resistant to efavirenz or relpeverin, for example. Currently, it's considered alternative because of limited data. So it's only been on the market for a couple of years. So, in time, it's likely that, either it becomes, first line, or, it might find its niche for patients who have resistance developed to other non-nukes. This concludes this presentation. I'm Dr. Fakir Abari, and this is Human Immunodeficiency Virus in Adults, Part 2. Here are the reliable resources for this topic. In particular, we are going to cover the 2021 CDC guidelines for pre-exposure prophylaxis for the prevention of HIV infection, which was updated in 2025 to add recommendations regarding injectable lenacapavir as HIV PrEP. We will also cover post-exposure prophylaxis. In particular, there are two guidelines: post-exposure prophylaxis in healthcare settings. This is occupational post-exposure prophylaxis. There's also non-occupational post-exposure, and the recommendations are similar between the two. The next learning objective is, given a patient at risk for exposure to HIV, recommend appropriate PrEP regimen. The 2021 guidelines for PrEP recommend that all sexually active patients should receive information about pre-exposure prophylaxis or PrEP. And of course, the ultimate goal of PrEP is to prevent the acquisition of HIV infection, along with its morbidity, mortality, and cost to individuals as well as society. PrEP is recommended for individuals who are at ongoing risk for HIV exposure, either from sexual behaviors or in individuals who inject drugs if they report injection practices that place them at risk. Now, one thing that is important is that acute and chronic HIV infection must be excluded by symptom history and HIV testing immediately before any pre-exposure prophylaxis regimen is prescribed. So let's take a look at how to exclude HIV. So clinicians should document a negative antibody test result within the 7 days before initiating PrEP. And this should be done ideally with an antigen antibody test. And it must be from the blood. So there should be a blood or serum sample. And it is preferred to have an antigen antibody test that's done in the laboratory. And that if that's not available, then a point of care antigen antibody test can be done still on the blood. Now, I emphasize that the sample needs to be from the blood because rapid tests that use oral fluids should not be used, specifically because they can be less sensitive than blood tests. So there would be high risk of false negative. The guidelines also state that clinicians should not accept patient-reported test results or documented anonymous test results. Now, let's take a look at the algorithm that's in the guidelines. So this is for people who are not on pre-exposure prophylaxis or any prophylaxis, including post-exposure prophylaxis. So for someone who is about to be initiated for the first time on PrEP, the antibody antigen test is preferred from the blood. And then if the results are positive, of course, this is considered HIV positive, and then they will be excluded from being initiated on pre-exposure prophylaxis, and then if in fact this is confirmed to be a true positive, then they need to be transitioned into treatment of HIV. Now for individuals where they either test negative or if there is indeterminate test, the next thing to consider is if they have had HIV exposure in the past 4 weeks, and if they have signs and symptoms of HIV, acute HIV infection. If the answer is no, because the results are either negative or indeterminate, it's safe to assume the patient does not have HIV, and it will be safe for them to initiate PrEP. Now, if the answer to this question is yes, a second test needs to be done from the plasma to confirm the results. So this can be either another antibody antigen assay, or it could be an RNA assay, HIV-1 RNA assay. And of course, if either of these are positive, the patient is HIV positive. If either of them are negative, it would be HIV negative, and then the patient can be started on PrEP. Now for the RNA assay, the level that would be significant would be 200 copies per ml. So if the level is less than 200 copies, for example, if it's 150, it could potentially be a false positive. So it is recommended to get another level and find out, if that's a false positive or negative. But in general, if it's at least 200 copies or higher, it's considered a positive result. Now here are the CDC recommendations for HIV pre-exposure prophylaxis that were released in 2021, and then they were updated in 2025 to add the lenacapavir to the recommendations. In general, we can think of 3 groups of people who qualify for pre-exposure prophylaxis. So men having sex with men or transgender women. The second group is heterosexual men and women. The third group is persons who inject drugs. And of course, we don't have data on pre-exposure prophylaxis in transgender men, and that's why they're not included in these recommendations. And then we can think of oral regimens and then injectable regimens. So the oral regimens, which should be dispensed in 90-day supplies, that way people will come back every 3 months for assessment and monitoring. Essentially, we have emtricitabine TDF daily or emtricitabine TAF daily. That's 1 pill once a day for MSM and transgender women. For heterosexual men and women, TAF has not been approved, so we only have emtricitabine TDF as oral daily regimen, and the same thing for persons who inject drugs. So TAF is not effective for these 2 groups, only for MSM and transgender women. For injection agents, we have cabotegravir, which is an intramuscular injection. It's in the gluteal muscle, so it is done in the clinic. For the initial dose, 600 milligram. Second dose is 4 weeks later, and then after that, starting from the third dose, it's going to be every 8 weeks, so approximately every 2 months. So that's good for adherence. We also have lenacapavir, which is the most recent one. This is a subcutaneous injection. This one, interestingly, has also a loading dose of oral lenacapavir for the first 2 days. So on day 1 and day 2, patients will receive an oral. These are actually a couple of pills each on day 1 and day 2. And then after that, it's an injectable every 6 months. So essentially 2 injections per year, which will really improve adherence. Now you can choose either injection or oral regimen, not both at the same time. And here are the criteria for identifying patients who qualify. So for the first 2 groups, if people have anal or vaginal sex in the past 6 months, and if they meet any of the following, either HIV positive sexual partner, or if they had bacterial sexually transmitted infection in the past 6 months, or history of inconsistent or no condom use with sexual partners. For people who inject drugs, if they have HIV positive injecting partner, or if they participate in sharing injection equipment, that kind of behavior will put them at risk of HIV, so they qualify for PrEP. Now, for clinical eligibility, there has to be a documented negative HIV antigen antibody test result within 1 week, so it could be in the past 7 days, before initiating PrEP. This is important to exclude HIV because these regimens are incomplete full treatments of HIV. So if people do have underlying HIV infection, that will result in resistance. So it's important to rule out unidentified HIV infection. So we screen there has to be no signs and symptoms of acute HIV infection. And of course, depending on the agent, there should be no contraindications. And for oral regimens specifically, there are creatinine clearance cutoffs. So if the regimen includes TAF, creatinine clearance has to be at least 30 or higher. If it's TDF, creatinine clearance has to be at least 60 or higher. And these are for prevention only, for prophylaxis use. If TAF or TDF are used for treatment, these cutoffs do not apply. So refer to those cutoffs for treatment regimens. And there are no creatinine clearance cutoffs for cabotegravir and lenacapavir. Now let's take a look at the options. So in general, efficacy of PrEP, either oral or injectable, it is dependent on adherence to ensure that plasma drug levels reach a protective level. It's important to note that the time from initiation of PrEP to maximum protection against HIV infection is unknown. So when somebody initiates these, it's not clear if they have the protection immediately or, a few days later. But we do know from pharmacokinetic studies, specifically from Truvada, is that we get enough concentrations of Truvada in different sites. So it really depends on the site. So if it's, for example, people who inject drugs, the site of infection will be blood. So some sources say it will take 7 days, others say 20 days. So it's safe to assume that somewhere, in the first, it will probably take around 2 to 3 weeks before this pre-exposure prophylaxis is fully effective in preventing HIV infection through blood. And that's 20 days in cervical-vaginal tissue. So for women, this makes a woman participating in vaginal intercourse. The cutoff is 20 days. For rectal tissue, which is the primary route for men having sex with men, as well as also for women, that could be the route of intercourse. So 7 days. And it's faster for rectal because these are oral regimens. So it goes through the mouth all the way through the colon. So it goes, because these are oral regimens, they go to the site that's of interest immediately, whereas for cervical-vaginal tissue, it needs to be absorbed first and go into the blood, and then blood needs to go to the vaginal tissue and transfuse for this drug to achieve concentration. So it's longer. It takes longer to get enough concentrations in the vaginal tissue, and we don't have any data in as far as penile tissue. Now, these are based on Truvada when it comes to Descovy, which was approved for PrEP in 2019. We don't really have the PK data, so it's not clear how long it will take. If we had to guess, it will probably be similar to Truvada, but the truth is that we just don't know. And as I mentioned before, Descovy has not been approved for heterosexual couples or people who inject drug. It just has not been studied. It has only been studied in MSM or transgender women. And of course, most recently, at the end of 2021, cabotegravir in long-acting was approved for pre-exposure prophylaxis. Now, because so here's the package, and it has one vial, so it only has cabotegravir in it. It does not have rilpivirine. So rilpivirine is only used with this when you have the full treatment. But for pre-exposure prophylaxis, it's only cabotegravir, so only one agent. Now, because it's a long-acting, it takes several weeks for the body to clear this. Some patients may have concerns about tolerability. So if somebody was to have a bad adverse effect to this, they will have that for several weeks. So there is an optional short-acting oral cabotegravir that they can try for 4 weeks just to make sure they don't have any adverse effects. But this is optional because it is extremely rare for patients to have intolerable adverse reactions to this drug, so that's optional. Just like the oral option, the time from initiation of PrEP with this regimen to protection is unknown, so it's not clear how long it would take. Now, because of the long half-life, there is this long tail of gradually declining drug levels. So if somebody wants to come off PrEP, then because of the long half-life, they're going to have the drug in their system for a long time, including once it goes subtherapeutic, they will have that subtherapeutic levels for a long time. So if they happen to get HIV infection during that time, they are at high risk of developing drug resistance. So that makes it tricky when somebody discontinues this. It's probably a good idea to go on oral PrEP if they are to have some exposure to HIV. Of course, if somebody knows for sure they're not going to have exposure to HIV, it's not going to be an issue just discontinuing this. Now let's take a look at lenacapavir. Yeztugo is the brand name for the formulation that's used for pre-exposure prophylaxis specifically, not for treatment, and it was approved in 2025. Now this one is required to have 2 days of oral regimen as a loading dose, so 600 milligram oral lenacapavir on day 1 and day 2, and then this is an injection every 6 months. Now, the time from initiation of PrEP to maximal protection against HIV infection is likely 2 hours after the dose on day 2. So that's why the loading dose is provided to increase the time to maximum benefit. Whereas if the 2 oral doses are skipped, it will take 21 to 28 days. So essentially about a month, 3 to 4 weeks. Until patients have protections. Thereafter, there is no need for oral regimen, so it's an injection, subcutaneous injection every 6 months. Now, because this is a long-acting agent, when discontinued, medication levels in the body decline over 18 months, starting 6 months after the last injection, which we call the long tail. And this is the significance of the long tail. So here on the y-axis, we're looking at drug concentration, and on the x-axis, we're looking at time. And imagine the blue line is an oral regimen for PrEP. So people take an oral, you have a peak, and then it's time for the next one. So you get multiple. Occasionally, if somebody skips a dose, the levels will go below the therapeutic levels, and it will go into the resistance zone. So resistance zone is essentially where the drug still exists. So we have some subtherapeutic levels of the drug where the virus can actually develop resistance to it. And then if the patient takes it again, it will go above. And then if you discontinue the regimen because there's no need for it or for other reasons, there will be a small window for the levels to be in the resistance zone until it becomes undetectable. Now, with long-acting agents, once the patient discontinues it, the level goes below therapeutic level, and then it will stay in the resistance zone for a very long time. And during this long time, if the patient no longer has a need for pre-exposure prophylaxis because the risk of exposure is no longer there, this is not a concern. But if the risk of exposure is there, and this is a patient who's non-adherent, this really exposes patients for a very long time to develop resistance, and that becomes problematic with these agents. Now let's look at the follow-up for monitoring. So it is recommended that for all patients to at least every 3 months to get the HIV testing, as I mentioned before, to make sure that if they test positive, they need to transition. This is primarily based on oral PrEP, so we're talking about Truvada and Descovy. So if they do test positive, they need to be transitions to ART, and the HIV testing is a combination of antigen antibody and RNA assay, which I'll explain shortly. And then because of the risk factors for getting HIV and STIs are the same, so bacterial STI screening is also recommended. Now it's recommended more frequently for MSM and transgender women, so every 3 months, whereas for everybody else, bacterial STI screening is recommended every 6 months. And of course, as part of these every 3 months, it's important to assess signs and symptoms of acute HIV, as well as side effect assessment, so we can manage side effects to improve adherence. There could be other reasons for non-adherence, so it's important to do a full adherence assessment and provide support to patients. And depending on what risk factors they have, it's also important to continue to assess those risk factors, because if they don't have those risk factors, then they may not need to be on PrEP continuously. So if somebody doesn't have those risky behaviors anymore, they can come off PrEP. And for people who inject drug, it is important to assess access to clean needles and syringe. And in fact, it would be important to provide to them clean needles and syringes, because if we don't, what ends up happening is that patients just share needles or use dirty needles that they find at various places. Of course, for women, it's important to do pregnancy tests. Now, if somebody is receiving tenofovir-based PrEP, it's important to assess renal function. If they are aged 50 years or older, or at baseline their creatinine count is less than 90, the renal function needs to be assessed every 6 months. Otherwise, if somebody is younger than 50, or if their renal function is greater than 90 at baseline, they can just be assessed every 12 months for renal function. And then every 12 months also, it is important to assess weight and lipid panel if they are receiving TAF. So TAF only, TAF specifically is associated with weight gain and dyslipidemia. So that does not apply to TDF. And lastly, evaluate the need to continue PrEP annually. For the injectable cabotegravir, which is injected every 8 weeks or every 2 months, again, at 1 month after the first injections, it's important to get HIV testing, as well as checking for acute HIV and assess risky behaviors. And then every 2 months, and the reason these are shorter follow-ups is because they match the time that the patient has to come back to the clinic to get the injections. So essentially, these are every 2-month injections. So if the patient is coming back to the clinic to get the injections, then there's opportunity to do HIV testing and make sure that they have access to clean needles and all the other things that we need to do. So at every 4 months, it's important to get STI screening for MSM. Every 6 months, STI screening for everybody else. Every 12 months, assess desire to continue injections. So in other words, PrEP is kind of like birth control. So, people don't need to be on it forever, but as long as they have risk of being exposed, the same way that, for birth control, as long as somebody doesn't want to be pregnant, they receive birth control, but it's not for life. The same applies to PrEP. As long as somebody is at risk of being exposed to HIV, they can be on PrEP. But if those risk factors go away, for example, let's say they stop injecting drug, or if they change their partner and they're no longer being exposed to a sexual partner with HIV, then they no longer need to be on PrEP. And that's something that needs to be assessed every 12 months. Now, the monitoring for lenacapavir is more straightforward. This is every 6 months injection. So most of the monitoring is every 6 months. Now, it is recommended to consider an initial follow-up at 1 month. So it will essentially be everything you do at 6 months, do it at 1 month. But again, that's optional depending on a case-by-case basis. So every 6 months, again, you want to test for HIV, assess for adverse reactions, including injection site reactions, assess signs and symptoms of acute HIV, because if the patient does develop HIV, they need to be switched to full treatment. Identify significant drug interactions or contraindications, screen for STIs, and consider doxycycline post-exposure prophylaxis when indicated for sexually transmitted infections. evaluate social support and other care needs, and risky behavior assessment and support, access to clean needles and syringes and drug treatment services for people who inject drugs, assess desire to continue injection for pre-exposure prophylaxis. And when discontinuing lenacapavir, re-educate patients about the risks during declining lenacapavir levels during the long tail, assess ongoing HIV risk and prevention plans, and if PrEP is indicated, but the patient no longer wants the injection, prescribe daily oral pre-exposure prophylaxis within 6 months after the last injection. The last injection will continue to protect the patient for 6 more months. Now, when it comes to adherence assessment and support, there are several approaches that can be effective. One is educating patients about their medications, helping them anticipate and manage side effects, asking about adherence success and issues at follow-up visits. So for example, you can say something like, many people find it difficult to take a medicine every day. Thinking about the last week, on how many days have you not taken your medicine? So this is asking, well, first of all, you make sure that the patient feels safe. So by making it, non-judgmental, that this can happen to a lot of people. And then secondly, asking an open-ended question so the patient can open up about their adherence. And helping them establish dosing routines that mesh with their work and social schedules. And providing a reminder system and tools. Addressing financial substance use disorder or mental health needs that may impede adherence, and facilitating social support. And of course, one counseling point is patients should be told to take a single missed dose as soon as they remember it, unless it is almost time for the next dose. If it's time for the next dose, they can just skip it and continue the regular dosing schedule. Please pause this video and review these key components of oral medication adherence counseling. Lastly, the Senate Bill 159 in California came into effect in July of 2020, and this is important because this new addition to the bill essentially lets a pharmacist furnish or dispense HIV PrEP as well as HIV post-exposure prophylaxis. In this part, I'm going to focus on the pre-exposure prophylaxis. And the bill says a pharmacist shall complete a training program approved by the board, which we provide that here in the school through this course. And then a pharmacist shall furnish at least a 30-day supply and up to a 60-day supply of PrEP if all of the following conditions are met. Now, this is slightly different than the guideline, because the guideline, which is in general for physicians, the limit is up to 90 days. For a pharmacist is up to 60-day supply, but at least a 30-day supply until, and this is essentially to link them to care so they can follow up with a primary care physician. Now, it is important before a pharmacist can furnish this to make sure the patient is HIV negative, and this must be based on blood, not the oral saliva test, and it must be within the past 7 days. No self-reported signs or symptoms of acute infection, no currently taking contraindicated medications, and the pharmacist provides counseling to the patient on the ongoing use of PrEP, which may include education about side effects, safety during pregnancy and breastfeeding, adherence to recommended dosing, and importance of timely testing and treatment as applicable for HIV, renal function, Hep B, Hep C, STIs, and pregnancy for individuals of childbearing capacity. And the pharmacist shall notify the patient that the patient must be seen by primary care provider to receive subsequent prescriptions for PrEP, and that the pharmacist may not furnish a 60-day supply of PrEP to a single patient more than once every 2 years. And the pharmacist initiating or furnishing PrEP shall not permit the person to whom the drug is furnished to waive the consultation required by the board. So they cannot waive all of this information. You are required to provide all this education to the patient. We looked at CDC recommendations for appropriate HIV pre-exposure prophylaxis in patients at risk for exposure to HIV. Now, given an HIV-exposed patient, let's recommend appropriate post-exposure prophylaxis regimen. Here are the recommendations from the 2025 CDC guidelines for non-occupational post-exposure prophylaxis, which are largely pretty much the same for occupational post-exposure prophylaxis as well. So for HIV post-exposure prophylaxis, it is recommended to be started as soon as possible after an exposure within 72 hours. So after 72 hours, it's no longer recommended, and it's best to start it within 24 hours. And exposure essentially can be sexual, needle, or other HIV exposures. Evidence is insufficient to recommend post-exposure prophylaxis after 72 hours. And the standard of care is to take a full 4 weeks or 28-day course of treatment. And the preferred agents include bictegravir, emtricitabine, tenofovir, alafenavoid, which is available as a single tablet. This is a once daily dosing for 28 days. Another preferred is dolutegravir with a nuke backbone. So either emtricitabine or lamivudine as the first nuke, and one of the two tenofovirs as a backbone. And because dolutegravir does not come in a single tablet with these nukes, you need at least 2 nukes. So this is essentially at least 2 pills. And again, once a day dosing for 28 days. Alternatively, a boosted darunavir regimen, and the pharmacokinetic booster can be either cobicistat or ritonavir, plus double nuke backbone, so emtricitabine or lamivudine as the first nuke, and one of the tenofovir formulations as the second nuke. It is not recommended to use abacavir-based backbone because there is no time for HLA-B 5701 testing, and because by the time the results come back, we will be outside of the 72-hour window. Raltegravir-based regimens used to be preferred previously. With these guidelines, they are no longer recommended because of the pill burden. So not only you will have to take raltegravir separate from the nuke backbone, but also raltegravir for this indication has to be dosed 2 times a day. So that would be unnecessary pill burden, given that we have better options as first line. And it's important to assess for potential drug-drug interactions when starting patients on these regimens. Now let's take a look at HIV PEP in the setting of sexual exposure. So once somebody has possible sexual exposure, of course, if it's been more than 72 hours since exposure, PEP is not recommended. Within 72 hours, then we can consider post-exposure prophylaxis. Now, if somebody was having protected sex, so intact condom use, there is again no need for post-exposure prophylaxis. For people who are having oral genital sexual contact without condom, it is not routinely recommended. However, you can consider it on a case-by-case basis. For example, if someone has a ulcer in their mouth, or if there is visible blood involved, you can initiate post-exposure prophylaxis. For other sexual encounters such as anal or vaginal intercourse without a condom, if someone is taking pre-exposure prophylaxis, they do not need to receive post-exposure prophylaxis. That is exactly what pre-exposure prophylaxis is for. So for these exposures, they will be protected from PrEP. Now, if somebody is not taking PrEP and they had unprotected anal or vaginal intercourse, if the source is known to have HIV, of course, they need to be treated with post-exposure prophylaxis if they do not have if the source does not have a suppressed HIV viral load. If the source does have sustained viral suppression, then post-exposure prophylaxis is not routinely recommended because U equals U. If the source has undetectable viral load, is unlikely to transmit, so it's not recommended. If the source has unknown HIV status, of course, it should be case-by-case determination, which can result in post-exposure prophylaxis. And then if, for someone who had exposure, if the risk of exposure is ongoing, upon 28-day treatment, there should be transition to pre-exposure prophylaxis. Now let's take a look at the setting of injection exposure. So if someone it's been more than 72 hours since exposure, again, post-exposure prophylaxis is not recommended. Within 72 hours, if the source is known to have HIV and they happen to have sustained viral suppression, it can be on a case-by-case determination, because U equals U is essentially based on the sexual transmission. It's the studies that determine U equals U were not based on blood exposure. So, you can still consider post-exposure prophylaxis. And of course, if someone does have detectable or unknown viral load status, they should receive post-exposure prophylaxis. And then for other possible exposures, again, similarly, if it's been more than 72 hours, PEP is not recommended. Within 72 hours, you can look at different possibilities. Of note, kissing, mutual masturbation, exposure to body fluids not associated with HIV are not a risk factor for HIV transmission, so post-exposure prophylaxis is not routinely recommended. The same with human bites, and it says not routinely as opposed to not recommended, because again, you have to use your judgment. So if someone has an ulcer in their mouth, or there is visible blood, for example, in their saliva, those are cases that you should consider post-exposure prophylaxis. Injury from discarded needles in the community, post-exposure prophylaxis is not recommended unless, for example, there is freshly bloody discarded needles were involved. But if these are older needles, the risk is not real. Now let's take a look at what's recommended for monitoring in post-exposure prophylaxis. So essentially at baseline, if the source is, if the person who is the source of exposure is available, there's certain tests recommended at baseline, and of course the person who is exposed, there are recommendations for baseline, and baseline essentially means prior to starting post-exposure prophylaxis. So an HIV test is of course recommended both in the source and the person who's exposed, and antigen antibody testing is sufficient, but you can also use nucleic acid test, and especially if either party has been exposed to injectable antiretroviral agents in the past 6 months, it is recommended to use nucleic acid test, because exposure to injectable antiretrovirals could delay seroconversion, so it's possible that antigen antibody will not be detected in case they do have HIV, whereas nucleic acid test can detect that, is more likely to detect it. Other things, hepatitis B serology is recommended to be tested in both parties. Hep C antibodies in the person who is exposed, and RNA nucleic acid test for Hep C is recommended for the source. And then for as far as setting baseline for monitoring safety, these are only for the person who is exposed, because we're about to start post-exposure prophylaxis in those patients. So it's important to get serum creatinine and liver enzymes at baseline. And then these are for everybody. And then if the exposure is a sexual exposure, then we should also consider some testing for example, sexually transmitted infections. So syphilis serology is recommended in both parties. Also, nucleic acid amplification tests for gonorrhea and chlamydia in both parties. And then for pregnancy, for all women of childbearing potential who are not known to be pregnant, it is recommended for the person who is exposed to get the baseline pregnancy test. And then the next set of monitoring would be 4 to 6 weeks after exposure, and this is essentially at the end of treatment, because post-exposure prophylaxis is for 4 weeks. So at the end, we do either antigen antibody or HIV nucleic acid test. And this may be unnecessary if post-exposure prophylaxis was started within 24 hours. But if it took more than 24 hours, it's important to check because the risk of post-exposure prophylaxis not working is higher if it took more than 24 hours. And then ultimately, 12 weeks after exposure, which is at 3 months, an HIV test is to establish whether post-exposure prophylaxis was successful or not. So if this test is negative, conclude that post-exposure prophylaxis was successful. Otherwise, if this is positive, the patient will transition to HIV treatment moving forward. For Hep B serology and Hep C antibodies, there's no need for testing beyond baseline. The Hep C RNA test is recommended 4 to 6 weeks if the source tested positive at baseline, just to make sure that the person did not get Hep C. And if they did, we will transition to treating Hep C moving forward. And then serum creatine and liver enzymes recommended at 4 to 6 weeks if they were abnormal at baseline. For syphilis, it is recommended if initial syphilis testing negative and infection in the source cannot be ruled out, follow-up testing may be performed 4 to 6 weeks and 3 months post-exposure. For gonorrhea and chlamydia, there is no need for follow-up, and one more pregnancy test at 4 to 6 weeks. And as I mentioned previously, if the risk of exposure is ongoing, an immediate transition from post-exposure prophylaxis to PrEP, including HIV testing at the completion of the PEP regimen with a prompt transition to a recommended PrEP regimen might be beneficial for persons with anticipated repeat or ongoing potential HIV exposure. So here's how the transition works. So whatever the post-exposure prophylaxis was selected, so either bictegravir or a dolutegravir based regimen or darunavir based regimen, essentially once the 28 days of treatment is over and the person is negative for HIV, they will transition to one of the pre-exposure prophylaxis. So either this is not there are more options that are not listed here, but any pre-exposure prophylaxis regimen that's available on the market, the patient can qualify for. Now, the Senate Bill 159, SB 159, that will be effective July 2020, expanded services of pharmacists to HIV PrEP as well as HIV PEP. So pharmacists can furnish HIV post-exposure prophylaxis starting July of 2020, as long as the pharmacy gets a training in it. So typically, I imagine a 1 hour CE will be required, or maybe if more CEs. But most importantly, the pharmacists can furnish a complete course. Now, they don't specify what complete course is, but they do say that, they will be referring to the CDC non-occupational post-exposure prophylaxis guideline, which would define the complete course as 28 days. So what they really mean here is a 28-day course of post-exposure prophylaxis. And then they follow the same requirements as the CDC guidelines. So it has to be within 72 hours of exposure. And just like PrEP, the pharmacist is required to provide the full counseling to the patient, including transition to PrEP. And the patient may not actually waive this consultation. So it's actually... We looked at CDC recommendations for appropriate pre-exposure prophylaxis in patients at risk for exposure to HIV. And then given an HIV-exposed patient, we recommended appropriate post-exposure prophylaxis regimen. Now, given an HIV patient case, evaluate and manage common drug-drug interactions.
So when it comes to the pharmacokinetic boosters, we have cobicistat and ritonavir. Cobicistat is actually not an HIV drug, so it has no activity against HIV. Ritonavir itself is a HIV protease inhibitor. However, we actually don't use it for its protease inhibition because we use a lower dose. It's such a potent inhibitor of these enzymes that we actually use it at suboptimal doses. So the doses, 100 milligram of ritonavir is not enough to be active against HIV, but 100 milligram is such a potent inhibitor of these enzymes that we actually use it to boost the concentrations of other protease inhibitors. So you can see there are some differences between the two. One thing in particular about cobicistat is that it can actually artificially increase serum creatinine, and that's because it actually inhibits some of the secretion of serum creatinine. So it really does nothing to the GFR. So, obviously integrase strand transfer inhibitors are primarily the first line agents that we use for treatment of HIV. So currently we have 4 on the market: raltegravir, dolutegravir, bictegravir, and bictegravir. Bictegravir is the only one that needs to be taken with food. They're pretty much all taken daily. Up until recently, raltegravir had to be taken twice a day, but now there's a new higher dose of it that you can actually take once a day. In particular, bictegravir and bictegravir are actually substrates of 3A4. So bictegravir itself actually needs to be boosted. So cobicistat will inhibit CYP3A4. So as a result, you will need less of bictegravir. So the pills will be smaller, and also with the half-life that's a little shorter, 13 hours, you can still dose bictegravir once a day because of that pharmacokinetic booster. Now, bictegravir, although it is a substrate of 3A4, it does not need boosting. So you need smaller doses of bictegravir, so 50 milligrams. So also the pill is smaller than bictegravir. So that's another reason that boosting was not needed for bictegravir, because for 50 milligrams the pill was small enough, whereas bictegravir, even with a booster, you still need 150 milligrams. So if you didn't have that booster, you would probably need several times 150 milligrams. So when it comes to drug interactions, bictegravir will have the most, not because of bictegravir itself, but because it has to come with cobicistat. So cobicistat will cause a lot of drug interactions, whereas the rest of them don't have a pharmacokinetic booster. One thing that bictegravir and dolutegravir have in common is that they both inhibit OCT2, and one thing that's important is metformin is actually a substrate of OCT2. So OCT2 is it's actually its function is to actually secrete metformin. So because they inhibit, you will see metformin levels increased. So that would be a significant drug interaction, because you will see a lot of diabetic patients on metformin. Bictegravir also inhibits MATE1. So let's look at some clinically significant drug interaction. So all integrase strand transfer inhibitors will interact with cations like antacids. So any polyvalent cation containing like aluminum or calcium, they will actually bind to integrase inhibitors and will prevent their absorption. So for that reason, anything that contains a polyvalent cation should be avoided, or actually should be spaced out by 2 hours. So 2 hours before or after you give integrase strand transfer inhibitors. So all 4 of them will interact with antacids, or not just antacids, anything that has. So if you were giving calcium pills, or anything that has a polyvalent cation. One thing that bictegravir and dolutegravir have in common is that they both will interact with metformin and dofetilide. So when it says avoid, when I say avoid, I actually mean contraindicated. So dofetilide is actually contraindicated with bictegravir and dolutegravir. Metformin is not a contraindication, so you just adjust the dose. Now, there's a really good chance that cobicistat may also interact with dofetilide. However, it's not in the package insert at the moment. So they may just not have studied it, but be careful with cobicistat and dofetilide. I didn't see it in the package insert, but I suspect cobicistat will also interact with dofetilide. Bictegravir is also contraindicated with rifampin because rifampin is a strong inducer of CYP3A4 and bictegravir is a substrate, so rifampin should be avoided. With elvitegravir, it's recommended to avoid anything that's a substrate of CYP3A4, like these statins are actually substrates of CYP3A4, and because cobicistat is a strong inhibitor, it's actually contraindicated to use these two. It is okay to use atorvastatin. The same goes with salmeterol. And then rifampin, of course, is a strong inducer of CYP3A4. That actually, because you actually need a pharmacokinetic booster for elvitegravir, so cobicistat is a strong inhibitor of CYP3A4, and rifampin is a strong inducer, so you should it's actually contraindicated to use rifampin because it will mess up elvitegravir levels. The same with some of the anticonvulsants like phenytoin. They're also inducers, so pretty much most inducers of CYP3A4 should not be used with elvitegravir because it needs help from a pharmacokinetic booster. And then, of course, because of cobicistat, patients use caution with hormonal contraceptives because cobicistat can inhibit and cause failure of hormonal contraceptives. When it comes to protease inhibitor, of course, these are the three most common protease inhibitors, and of course they're boosted. And the reason they can be boosted is because they're all substrates of 3A4, so they're not usually renally cleared. And for non-nukes, so efavirenz and rilpivirine are the two common ones that you use. Etravirenz actually, for food, you should take it after each meal. Food can actually increase etravirenz by 50%, so it's recommended to take it after meals. It doesn't necessarily mean empty stomach, but it just says take it after meals rather than with food. Now, these are all CYP3A4 substrates. One thing that's special about efavirenz is that it's actually an inducer of CYP3A4. So you will also see a lot of drug interactions with efavirenz. So for protease inhibitors here and rilpivirine, here are some clinically significant drug interactions. So again, because protease inhibitors are boosted, you should avoid substrates of CYP3A4. So here are the three statins that are substrates of CYP3A4. Atorvastatin also has a separate mechanism of clearance, so it's not as strong. So it's only listed here for because it's in the package insert for atazanavir, boosted atazanavir, but it's okay to use atorvastatin with darunavir. There are also hepatitis C protease inhibitors that are also substrates of CYP3A4, so they should be avoided because these are boosted and the boosting will affect the levels of hep C drugs. And the same can be said about salmeterol. Now, atazanavir and rilpivirine both need an acidic environment for absorption. So with atazanavir and with rilpivirine, it's you should actually avoid proton pump inhibitors because they need the acidic environment.
Let's take a look at some common drug interactions. When it comes to drug interactions, you will see that the majority of significant drug interactions are with boosted regimens, so either boosted protease inhibitors, so atazanavir, darunavir, and lopinavir are boosted with ritonavir or with cobicistat. And of course, elvitegravir is the only integrase strand transfer inhibitor that's boosted with cobicistat. And because these pharmacokinetic boosters are CYP enzyme inhibitors, they lead to significant drug interactions. Now, when it comes to corticosteroids, you will see that beclomethasone, which is available as both the nasal formulation as well as inhalation, is pretty much safe to take with any regimen. Now, for the sake of this discussion, we're going to ignore any topical formulations. Budesonide is available as inhaled and intranasal formulation, but it is also available as systemic formulation, so it can be taken orally. And you will see that it's contraindicated with any pharmacokinetic booster, so it's not it should be avoided with the boosted PIs as well as bictegravir. Now, it does interact with efavirenz because efavirenz is an inducer, but it's not really contraindicated. So you just have to monitor and make adjustments to the dose of budesonide. Now, systemic dexamethasone itself is a inducer, so it can actually reduce the concentration of protease inhibitors and bictegravir. So it should be monitored and dose adjustments must be made. But the interaction is significant with rilpivirine, so it actually should be avoided with rilpivirine. Now, fluticasone is available as inhaled and intranasal, and both the routes are actually contraindicated with boosted PI or boosted bictegravir. Mometasone as well is available as intranasal or inhaled formulation, and both routes are contraindicated with cobicistat and with boosted protease inhibitors. Prednisone is systemic, and it does interact, but it's not contraindicated with boosted regimens and efavirenz. Salmeterol is inhaled. While it does interact, it's not contraindicated. So anything that's yellow, it potentially interacts, but it's not contraindicated, whereas the red boxes are contraindicated and should be avoided. And the green, of course, means no significant interactions. Now, triamcinolone is also available as inhaled or intranasal. It does interact with boosted regimens and efavirenz, but it's not recommended. Of note, triamcinolone, fluticasone, and budesonide are also available over the counter as intranasal formulations. So as pharmacists, it is very important to provide education to patients who can easily walk to the shelves and grab any over-the-counter products. So if they are on these boosted regimens, it's important to let them know that fluticasone and budesonide over the counter are contraindicated, and triamcinolone would be the safer option should they need intranasal corticosteroids for seasonal allergies, for example. So that's an important education to provide to patients. Now, when it comes to some of the cardiovascular agents, of note, amlodipine and diltiazem are two commonly used calcium channel blockers. Because they are also substrates of CYP enzymes, they do interact with boosted regimens as well as efavirenz. However, they are not contraindicated, so you just have to monitor the patient's blood pressure and heart rate with diltiazem and make adjustments to the dose of amlodipine and diltiazem based on their blood pressure and heart rate. Okay, so we are here at the local Walmart. We're gonna go check out the pharmacy. You know where the pharmacy is? Okay. Okay, so I'm looking for over-the-counter allergy relief. Okay, so they have Flonase and Nasocort. Oh, Cecilia, you're here. I have a HIV patient who's taking boosted regimen. They want Flonase. What do you think?
Flonase. No, that's a terrible idea. Flonase will interact with boosted regimen and non-nukes.
Oh, what should I do then?
Go this way. Nasocort.
Nasocort?
Yes.
Oh, thank you.
I'm here to help you.
When it comes to hormonal contraceptives, CYP3A4 has a role, so both efavirenz and ritonavir can affect the levels of progestins. So because of that, it is recommended to use additional contraceptive methods when the patient is actually taking efavirenz or boosted regimens. So with these, they're not really contraindications, but it's important to let the patient know that these can make hormonal contraceptives ineffective or less effective. So they should use alternative methods of contraception. So primarily with boosted and efavirenz. So as I mentioned before with statins, basically the three statins that go through CYP3A4 are listed here, but atorvastatin in particular doesn't primarily depend on 3A4. So historically atorvastatin was considered a drug interaction with anything that affected 3A4, but nowadays we have data that atorvastatin is not as much affected. So the only exception is that with atazanavir, atorvastatin is actually contraindicated. But with darunavir, for example, they just recommend the maximum dose. But it's okay to use atorvastatin with darunavir. So these two contraindicated with anything that has cobicistat or ritonavir. So anything that's boosted.
We looked at pre-exposure and post-exposure regimens. We evaluated drug-drug interactions. Now, given a patient case where an adult patient with HIV is experiencing intolerable adverse effects, recommend appropriate management.
So when it comes to adverse effects, of course, our the newest nukes actually are generally well tolerated, whereas the older nukes had severe toxicity. So mostly because of mitochondrial toxicity. So zidovudine, which is one of the oldest ones from the 80s, and we still use it because it's available in IV formulation, and also we have significant data in pregnancy. So it has all of those terrible side effects that all the old nukes have. Now with abacavir, of course, you can have hypersensitivity reaction, so it's important to check for HLA-B 5701 polymorphism. TDF is nephrotoxic and bone mineral loss, so osteotoxicity. And TAF is an improved version of TDF, so it's well tolerated. So it can still cause some nephrotoxicity and bone mineral loss, but it's not to the extent of TDF. And emtricitabine can also cause hyperpigmentation. So when it comes to, so you can see they have looked at the bone mineral density over 48 weeks in different studies, and they can see how much bone mineral density loss has occurred once the drugs have been studied. So you can see that most bone mineral density loss occurs in the studies that actually has TDF. So tenofovir disoproxil fumarate, you can see all these yellow or orange, I guess, all these orange lines. There's significantly more bone mineral loss, whereas when we change that TDF to TAF, TAF is significantly less bone mineral loss compared to the other formulations that have TDF. Now, with the integrated strand transfer inhibitors, which are first-line recommended regimens, are pretty well tolerated in general, and so they are both effective and well tolerated, and they actually do pretty well against resistance. So that's why they are recommended first-line. One thing about dolutegravir, it can actually increase creatine phosphate kinase or CPK. With elvitegravir, you can actually see proteinuria. And when it comes to boosted protease inhibitors, darunavir is well tolerated. Lopinavir is a relatively older protease inhibitor, so you will see more adverse effects, especially some changes on EKG. Atazanavir can actually cause jaundice, so in a lot of areas they actually call it bananavir. So bananavir because it's common to see jaundice in patients. So because of that, because of toxicity, actually, these two agents are not used as much anymore. Darunavir is better tolerated, so should we need protease inhibitor, typically darunavir is the drug of choice. And the reason we would need protease inhibitor is because they actually do significantly better against resistant HIV, even compared to second generation integrase inhibitors. So they are, typically when patients experience treatment failure because of resistance, protease inhibitors are drugs that we go to. But because of these side effects, and also drug interactions, we don't use them initially in someone who's treatment naive. So with the non-nukes, the two that you will commonly see are efavirenz and rilpivirine. Rilpivirine is actually well tolerated. The reason we don't use it first line is because for rilpivirine to be effective, the CD4 count needs to be greater than 200 and a viral load less than 100,000 at baseline to start it. So that's, considering how many other options we have, that's a lot of things to look at. So rilpivirine is not first line anymore. But efavirenz actually has CNS toxicity. So one thing that a lot of patients will complain about is vivid dreams. So they could be so much that that the patient will actually stop taking it. Now, for a lot of patients, these are supposed to go away after 2 to 4 weeks of treatment. But if they persist after 4 weeks, then it's a good idea to switch them to something else, because as time goes on, this can lead to non-adherence. Another thing that's important, this CNS toxicity can also cause suicidal ideation, and that's actually the primary reason efavirenz is not first line anymore, because it actually increased the odds of suicide attempt and completion. As I mentioned earlier, cobicistat can actually block MAT1 or MAT1, and MAT1 can actually secrete creatinine. So by blocking this, it artificially artificially increases the levels of creatinine in the blood. So it doesn't really change GFR, but it can artificially increase serum creatinine. So here are some numbers. So cobicistat, because it increases serum creatinine, if you're using Cockcroft-Gault equation to calculate creatinine clearance, you will automatically get the number that's 15, can be up to 15 milliliters per minute lower. So now rilpivirine and dolutegravir also have some, they also can increase serum creatinine, so keep that in mind. So when it comes to different regimens, it's important to consider renal function. So this is creatinine clearance cutoff. So for elvitegravir, cobicistat, emtricitabine, whether it's with TDF. So this is Stribilt. So with Stribilt, it's actually, so if the patient creatinine clearance is less than 70, it's not recommended to initiate it. So in order to start Stribilt, which has both cobicistat and TDF, which can affect creatinine clearance, it has to be greater than 70. Now, if it's somebody's creatinine clearance is 72, and you started and it goes to 65, you can continue. But if it goes below 50, then it's recommended to discontinue, and that's in the package insert. Now, with darunavir, cobicistat, and TDF, the cutoff is also 70, but they don't really say anything about once it goes less than 70. So once it goes less than 70, you have to discontinue it because it doesn't have a statement about going less than 50. But with Stribal, definitely you can continue until it's less than 50. Once it's less than 50, you discontinue. But with darunavir, cobicistat, once it's less than 70, you discontinue. So you can see the cutoff for some of the other agents. So for most of them, whether it's TDF or dolutegravir, it's 50. If you use the TAF formulation, anything with TAF, whether there is cobicistat or not, with TAF the cutoff is 30. So definitely that improved it. And most recently we have the combination that doesn't have the backbone, so there is no TDF or TAF. So we have a dolutegravir with rilpivirine, and renal function doesn't matter. So for these combination, you can use it at any creatinine clearance. So should someone need a reason to change their ART, whether it's because of intolerable adverse effects or because the renal function got worse, or whatever the reason, there are some basic principles that should be considered when switching, in patients who are virologically suppressed on the current regimen. So one thing, although they may be virologically suppressed on the current regimen, it's important to review their past history to make sure they didn't have resistance to regimens in the past. So if they did have resistance in the past, you want to avoid those agents. If they have had resistance in the past, it's important to consult an expert. Generally speaking, switching within the same class is not an issue. So if someone didn't tolerate efavirenz and you were to switch them to rilpivirine, it will be okay. However, if switching between classes is a little more tricky, so you really have to know what you're doing. So for example, if someone is on a protease inhibitor and you're about to switch them to a non-nuc, so if someone is on darunavir and you're about to switch them to efavirenz, you have to be careful and make sure that it will still be susceptible to efavirenz because you're switching between class. But generally speaking, it is possible to switch between classes if you don't have reason to believe that it will be resistant.
We looked at CDC recommendation for HIV pre-exposure prophylaxis and post-exposure prophylaxis. We evaluated and managed common drug-drug interactions, and we looked at patients who experienced intolerable adverse effects and how to manage them. Now, let's educate an HIV patient on important lifestyle modifications.
So now that we have really good, potent HIV regimens, our HIV patients are actually living longer. So now we have been able to actually study and see, how does aging affect HIV patients? Because before, patients would die within 10 years of having HIV. So we couldn't do these studies before. In fact, you can see that in the 1990s, a lot of patients would die as they age, like very quickly. And then, throughout 2000s, as we improve treatment, more and more patients are actually living longer compared to the non-HIV infected patients. And this was a study from Denmark. These comorbidities include hypertension, which is the most common one, but also you can see HIV patients are more likely to have MI. So when you compare, so orange is HIV infected, blue is HIV uninfected. You can see significant difference in MI, but also peripheral arterial disease, when it also CKD. So factors related to non-AIDS comorbidities, obviously aging is a huge part of it, but unfortunately we cannot do anything about aging.
And then the other thing is that chronic HIV infection will lead to chronic inflammation. So even in patients who have undetected viral load, there will be chronic inflammation. And as we know, inflammation can lead to fibrosis and multi-organ damage over many years.
There's ART toxicity, so whether it's TDF causing bone toxicity or nephrotoxicity. That's something important for the pharmacist to monitor. So if someone is losing bone density, you may want to intervene and switch them from TDF to TAF or other regimens that are not as toxic.
Another thing is that these patients, based on their risk factors, they could also be co-infected with other viruses such as hepatitis C.
Of course, obesity, exercise, and diet and smoking are the most important lifestyle modifications. And the reason is HIV patients are at high risk of having cardiovascular disease. And because of that, these are things that are associated with cardiovascular disease. So it is extremely important to provide education to HIV patients who would benefit from weight loss. It's important for them to exercise, and it's important to also give them education about diet. In fact, most HIV clinics actually have a dietitian as part of the team, so that they actually get a comprehensive education about diet. So dietitians have an important role in the care of the HIV patient. Now, when it comes to so you can provide education for weight loss, exercise, diet, and smoking. The most important out of all of this is smoking.
So these things can lead to inflammation, dyslipidemia, insulin resistance, and decreased physical functioning, which over time can lead to end organ disease such as cardiovascular disease, CKD, metabolic syndrome, and neuropsychiatric dysfunction. Again, most ART agents are generally well tolerated. When it comes to NRTIs or nukes, older NRTIs are more likely to cause dyslipidemia. Newer NRTIs are less likely to cause dyslipidemia. TAF in particular can increase triglyceride LDL and HDL. But overall, the ratio of total cholesterol to HDL is not changed. Newer NRTIs are unlikely to cause insulin resistance. Of course, we have discussed that TDF can, reduce bone mineral density, and TAF significantly less likely to do this. And when it comes to bone marrow suppression, this specifically happens with older NRTIs. So zidovudine is one of the older NRTIs that we still have on the market. And then with cardiovascular disease, bictegravir is associated with MI, which is kind of controversial because FDA has not found a correlation between bictegravir and MI, whereas some observational studies have. When it comes to integrase inhibitors, the boosted bictegravir is also likely to increase triglyceride, LDL, and HDL, but it doesn't really cause anything else. Protease inhibitors, especially the older ones, were associated with dyslipidemia. Darunavir and atazanavir are, they can still increase triglyceride, LDL, and HDL, but not as much as some of the older protease inhibitors. And then with NNRTIs or non-nukes, efavirenz in particular can slightly increase triglyceride, LDL, and HDL. So in the 2018 American Heart Association guidelines for cholesterol management, they actually added HIV patients as one of the risk factors for having atherosclerotic cardiovascular disease. So they did say that for patients who are 40 to 75 years of age with LDL 70 to 189, and this is in the absence of, clinical atherosclerotic cardiovascular disease, in the absence of diabetes. So if someone doesn't have those things, and LDL is 70 to 189, if you calculate the 10-year risk score and it's 7.5 or higher, then someone who is also infected with HIV, they can benefit from statins more. So if you had a patient who you weren't sure if you should start a statin, but they had HIV, so that can push you toward actually prescribing a statin because they're more likely to benefit from it. And of course, these are the statins that are recommended. which I'll explain in a minute. So the following year, in 2019, the American Heart Association actually released guidelines for cardiovascular disease in people living with HIV. So this is HIV specifically, and they had two types of recommendation. One was lifestyle optimization, and one was pharmacoprevention of cardiovascular disease in HIV. So at the top of the lifestyle optimization is smoking cessation, followed by limiting alcohol consumption, increasing physical activity on a regular basis, and of course they refer to the 2018 guideline for dietary guidelines, which emphasize vegetable, fruits, legume, healthy protein sources, whole grains, and non-tropical vegetable oils. And they wanted patients to limit intake of sweets, sugar sweetened and artificially sweetened beverages, as well as red meats. When it comes to pharmacoprevention, in general, there are 4 groups of patients who benefit from statin therapy. And this is similar to non-HIV infected patients, but this guideline, this algorithm is specific for HIV patients. So for secondary prevention, is basically someone who already had an MI, stroke, or peripheral arterial disease. So someone who already had an event, you want to prevent another event. So that would be secondary prevention. And these are patients aged 21 or older with clinical atherosclerotic cardiovascular disease, and they will be considered high risk. So they need high risk approach. The rest of the groups who need a statin would be primary prevention. So these are people who have not had an event yet, but we want to prevent them from having an event for the first time. So it would be, so the second group would be patients with a very high LDL, so LDL 190 or higher. That would be high risk. The third group would be the diabetic patients aged 40 to 75. And then the last group would be people without diabetes, without high LDL, and without clinical atherosclerotic cardiovascular disease. And in these patients, we calculate atherosclerotic cardiovascular disease. And they did have 3 different calculators that you can use. So the most famous one that's commonly used nowadays is the 10-year atherosclerotic cardiovascular disease risk score. And they did say that you can, if it's 7.5% risk or higher, they will be high risk. If it's less, it will be low risk. Now, they do say that these calculators did not have HIV patients in them. And in general, HIV patients are 1.5 to 2-fold. They have 1.5 to 2-fold greater risk of having cardiovascular disease. So whatever you calculate, it's more likely higher in people living with HIV. So for example, if you calculate it to be 6.5 in a HIV patient, it will likely be more than 7.5, so you can consider them high risk. And in high risk patients, basically you go to this green area. Of course, you start with lifestyle modification, so such as smoking cessation, and then you want to use a lipid-lowering drug therapy, statins primarily. Whereas for patients who have low risk, statin therapy may not be indicated. And then when it comes to smoking, they looked at smoking cessation in people who are infected with HIV and compared that to people who had smoking cessation but they did not have HIV. So here on the y-axis, we're looking at the incidence of myocardial infarction, and on the x-axis, we're looking at the time in years. So you can see that the lowest risk of MI is in patients who do not have HIV and who never smoked. And when you compare that to HIV positive patients who never smoked, you can see this is pretty similar. So this slightly higher in HIV patients who never smoked, but still higher in HIV positive patients. Now when you compare to people who were previously smokers and did not have HIV, so that's even a history of smoking increased the risk of MI more than HIV did. But when you compare former smokers who actually have HIV positive, you can see this is significantly higher. So a combination of HIV and smoking is very detrimental as far as incidence of MI. And you can see the maximum risk of MIs in patients who are HIV positive, who are current smokers. So, smoking cessation, you can see that it will reduce the rate of MI significantly. To make things worse, about half of people living with HIV in the US are current cigarette smokers. And cigarette smoking is not only a risk factor for MI, but also a risk factor for stroke, for lung disease such as lung cancer, emphysema, and infections such as bacterial pneumonia, tuberculosis, and pneumocystis jirovecii pneumonia. Now, one of the problems with smoking cessation is that for majority of patients, it's difficult to achieve smoking cessation. In fact, the rate happens to be in the long term about 12 to 15%, at least in the studies. So if you encounter patients who are unable to quit despite intensive intervention, including pharmacological intervention, an alternative goal for smokers who cannot quit is cutting down. And basically what that means is that reducing the number of cigarettes per day is actually has been shown to have survival advantage compared to heavier smoking. And studies have shown that most smokers living with HIV can successfully cut down their tobacco use within 24 weeks. So, when you provide education to patients, you can talk about weight loss, you can talk about statin therapy, you can talk about diet and exercise, but the number one recommendation to discuss with patients should be smoking cessation, or at least cutting down on cigarettes per day.